So I hear that you're waiting for this session since I think in every talk you have before, everybody talking about if you have a critical patient, do ABC, ABC, ABC. By the way, I am the AB. I'm the airway breathing guy. Also, I've been texted with, by my residents who are watching. So if you don't mind me, I love you, my residents. I don't know where's the camera, but it's there. We're going to talk, there will be 3 sessions, though we divide in 2 sessions. We'll talk about the upper airway. We'll talk about the congenital causes of stridor, laryngomalacia, vocal cord paralysis, subglottic stenosis. We'll talk in the session 2 about the lower cause of stridor, and we'll take the infectious, and then we'll go to the lower respiratory tract infections, bronchiolitis, pneumonia. Then we'll talk about asthma, foreign body, aspiration, cystic fibrosis, and primary ciliary dyskinesia. I think I'm blessed because I do have an hour and a half lunch, so I'll make myself available if there's any question. My style will be giving you tips so you can help you through these slides, because you will have these slides, you can read them, but I think I will do my best to give you tips to remember them in the board and help you through your board. What I want to start with, I want to differentiate between, or when you talk about the upper airway, I want you to think about the sounds and these 4 things. So when we talk about the snoring, because sometimes it gets mixed up with the stridor, snoring happens only at night, because when we go in deep sleep, REM sleep, that's when we relax our muscles to the most, involving the muscles of the upper airway. So you over-relax your muscles, and then you close up your throat, if you have, especially in kids, if you have tonsil adenoid. Then you push air out with the pressure to open up the airway. That's what vibrates what's in the back of the throat, producing the snoring sounds. So you snore to open up your airway, but this is snoring. This is not stridor. The other thing I want you, when you think about upper airway, think about hoarseness. Think about the voice, the quality of the voice, muffled, hoarse, or normally cry. The other thing, the stridor, I want to remind you, and this could be also in the board, or you could be asked and get confused with, even in a clinical practice. We know that the upper airway diameter is smaller in the expiratory phase in a intrathoracic, and larger in the inspiratory phase intrathoracic, and the reverse in the upper airway. So if you narrow or you have upper airway obstruction and you have turbulence of flow, since the diameter in the inspiratory phase is smaller than the expiratory phase in the upper airway, you produce that stridor or that noisy breathing first in the inspiratory phase. So if you have an asthma attack and you have bronchospasms, then you will have an expiratory wheeze or sounds. Then if it progresses, you will have inspiratory wheeze. So it's expiratory, then inspiratory. So if you have a 6 years old with asthma attack, one with expiratory wheeze and the other one with expiratory and inspiratory wheeze, then the one with expiratory and inspiratory wheeze have more obstruction of his airway. Is that making sense? If you can tell me if there is an asthmatic who have an attack, you can come and listen and say, I hear inspiratory wheeze but no expiratory wheeze. Because it should be by pathophysiology, inspiratory wheeze, then expiratory wheeze. Expiratory wheeze, then inspiratory wheeze. If you hear inspiratory sounds without expiratory sounds, you move your stethoscope to the upper airway. So that's important to differentiate and to know. Now, I'll make this short. And we will talk about resistance. Kids' larynx or upper airway larynx are shorter and smaller. There is progressive growth of the larynx in the first 3 years. Then it will continue slowly growing up to puberty. So this means that you have a shorter diameter, which increases your airway resistance, and we'll come to that. And I want you to remember this airway resistance equation. It will help us all through pulmonology. Because if you think about it, we have airway and we have lung parenchyma, upper, lower airway. So we're talking about airway resistance. That could explain a lot of the pathophysiology. I want you to remember that any decrease in the diameter of the airway will increase the airway resistance to the power of 4. So if we go to the previous slide, since the larynx is smaller, then any inflammation, any narrowing of the larynx will increase the resistance of the larynx to the power of 4. And that will cause that turbulent flow producing the stridor. So that's why when you look at stridor, by the way, stridor is a sign. What's the symptom? Croup or bacchic cough. So if somebody comes, that's why if you hear there is a kid, since most of the larynx growth happen in the first 3 years, if you hear a kid who have a croupy cough after the age of 4 or 5, you start to question that. Isn't that true? Because of that growth that happened in the first 3 years. Now, a healthy 5-week-old born at term develops inspiratory stridor. His stridor increases with crying, supine position, and worsens his current stuffy nose. Which of the following is the most likely diagnosis? Laryngeal web, laryngomalacia, vocal cord paralysis, subglottic stenosis. That's good. So what you are agreeing, and this is the laryngomalacia, what you are agreeing that is laryngomalacia. So if we go back to the question, you are agreeing that this is a healthy kid, correct? Majority of these kids are healthy. So the prognosis is good. Laryngomalacia could disappear by itself up to the age of 2 years. You are agreeing also because in the exam, when you are in the exam, all these smart ideas start to come to you, and you never before. Then you look at it, it's like a 5-week-old. You said laryngomalacia is a congenital lesion. They should be congenital, means they're born with, correct? So how come 5 weeks old? Because we said develops 5 weeks old. So how come? Now maybe you change your answer? Okay, very good. So you have a flabby larynx, correct? It could take up to 2 to 6 weeks to show up. Why is that? If you have a floppy larynx, what will make the larynx collapse is the negative pressure we breathe in by vacuuming in air, correct? The -5 in physiology. So it's a dynamic obstruction. You have to create that negative pressure inside the larynx, and that will be the force that collapses your flabby larynx. Kids up to the age of 6 weeks, especially if it's a mild laryngomalacia, may not be able to create that negative pressure to cause that collapse. Is that making sense? And that's why, by the way, why kids breathe fast, normal breathing at 40 to 60, because they try not to take a deep tidal volume because of their recoil strength. So, now with the crying, why it increased? Because these are very characteristic things for laryngomalacia. Why with the crying? So we cry with what system? Sympathetic nervous system, which is beta agonist. So when we cry, we dilate our airway, including the larynx. So that's why if you are in the NICU or the NICU and somebody was diagnosed with tracheobronchomalacia, you try to avoid beta agonist. Because if you dilate a flabby airway, it will collapse. So we cry with sympathetic, we cry with beta agonist. That's why it worsens with the crying. Supine position, because the weight of the cricoid, thyroid, it collapses because it's floppy. And when we have a cold, you remember that equation we talked, if you decrease the diameter, it will increase the resistance to the power of 4. 50% of our airway resistance lies in the nose. So if you have a cold to the power of 4, you decrease the diameter, you increase the resistance to the power of 4, that will lead also from the kid to create a lot of negative pressure, -5 to -20, that will collapse the larynx. Is that making sense? Now, we talked about this. The most common cause, if you get asked, the most common cause of stridor in infant is congenital, and the most common congenital is laryngomalacia. And we talked about this. Typically could be 4 to 6, 12 to 14. I'll come to the dysphagia, apnea, cyanosis, and failure to thrive later on, because I can explain them. So you suspect a diagnosis of laryngomalacia. Which of the following procedure will confirm your diagnosis? Awake, flexible, fibro-optic laryngoscopy, high KV imaging of the airway, rigid bronchoscopy under anesthesia, a MRI imaging of the neck. And this time I will hit next. Excellent. So if you forget and you want to remember what Dr. Manna said, we said it's a dynamic obstruction. To catch a dynamic obstruction, you don't need a snapshot. You need something dynamic. And I said what caused the collapse is what the negative pressure created inside the larynx, correct? So you need to see it. The patient have to be awake, because if you put this kid to sleep, he will not produce that negative pressure inside the larynx to collapse it. So it's awake, and it should be visualized, okay? So that's good. And this is how it looks. You look how it's omega shape, and that's what I said. In inspiratory phase, it collapses, in that inspiratory phase, and you have complete obstruction or obstruction. You have confirmed the diagnosis of laryngomalacia. Which of the following statements describe the preferred treatment for this infant at this time? Supraglottoplasty, observation, tracheostomy tube, cricoid split. Next. Excellent. So supraglottoplasty is, by the way, it's the surgical procedure of choice for laryngomalacia. So when you observe for what? I mean, you put observation, correct? So observe for what? So there are two complications of a laryngomalacia, and we did this mistake. I did this mistake when I was rounding in the regular nursery. There is a kid who have stridor, said laryngomalacia, the nurse gave me 5, and then we're done. That was wrong, truly, because we need to observe, correct, for two things. So there are two, that's why I said I'll talk about these symptoms later on. There are two complications you have to remember, and I will explain them in laryngomalacia. The first one, aspiration, liquid aspiration. So you have a flabby larynx, and you suppose with the epiglottis to close it when the kid feed, correct? And so it will go to the right pipe, to the esophagus. So if you have a flabby larynx, that epiglottis will not be able to close it. And then it will leak, some of that milk will leak in the airway, so you get aspiration. When it leaks, you know what's the most important first line for protection against aspiration? Vocal cord. They go and adduct. When they adduct to prevent that milk getting to the airway, you'll be cyanotic. That's why they got cyanosis. Is that making sense? I said cyanosis before, you saw there. The second thing, so the first complication, feeding difficulties, namely aspiration. So if the kid have recurrent pneumonia, because he aspirates, and usually it's on the right side, recurrent pneumonia, recurrent low-grade fevers, aspiration, he become wheezy, because when that aspirated fluids goes to the airway, it will cause inflammation of the airway. It will narrow them, then to the power of 4, it will increase the resistance, and you will wheeze, and you will cough. And then, so that's one. The second one, when you go in deep sleep, as we talked, not because I'm a sleep doctor, you go in REM sleep, you relax your airway, or all muscles, include the airway, so your larynx relax more, it's already floppy, so it's over-relaxed, and you close up your larynx, you will produce obstructive sleep apnea. So the two indications for supraglottoplasty are feeding difficulties and obstructive sleep apnea. So you did choose observation because in that question that are healthy, 5 weeks old. But if they mention to you he has severe obstructive sleep, significant obstructive sleep apnea, he snores, he witness apnea, or he have recurrent pneumonia, cyanotic, then you say the answer is a supraglottoplasty. Is that? So we talked about the prognosis, supraglottoplasty, and we talked about liquid, suspected if infant, if he's choking, coughing because of aspiration, failure to thrive, because if you have obstructive sleep apnea, you start to spend more in worker breathing. If you aspirate, you will increase your worker breathing. That's why they have failure to thrive. And then snoring, respiratory distress, recurrent pneumonia. So you know these, and you know what to observe. A term neonate with hydrocephalus presents with respiratory distress and a high-pitched inspiratory stridor. In this scenario, the infant is at increased risk for stridor due to which of the following? Very good. So what you need to remember, and this is what you will need for the board for that bilateral, when they give you bilateral vocal cord paralysis, you go to the CNS. Most of the time, it's a central cause. So you have to get a CT, or actually, if ask me to confirm it, because in the board, it's very important to, if they said next step could be a CT scan available, is not that expensive. But if they ask you how to confirm what's really and rule out, you need MRI, because CT scan does not see the posterior fossa, where you will have not the hydrocephalus, you can see it in CT, but if you have Dandy Walker, if you have Arnold-Chiari, that put a pressure in your brainstem and the vagus and the recurrent laryngeal nerve, then you will not see it with a CT. Is that making sense? So when we talk about bivocal cord paralysis, you go central. You go to the brain. Find what's putting a compression in both recurrent laryngeal nerves. Is the third most common cause. And as I said, you have to rule out a central cause. When you come to unilateral, and this is the scenario, a kid who have a BDA ligation coming with a stridor. What's the diagnosis? Unilateral vocal cord paralysis. Because we will show you that how the recurrent laryngeal nerve, very close, in close proximity to the aortic arch, when they go for manipulate or to close the PTA or a cardiac surgery, and usually it's the left, you will have unilateral vocal cord paralysis. It could be also trauma at birth. So bilateral vocal cord paralysis, usually central, unilateral trauma, or after surgery. Okay? As he said, and now you should be able to know that. I said the vocal cords are the most important line of protection against aspiration. If your vocal cord cannot adduct to prevent liquid from going to the airway, you will aspirate. So if you have vocal cord paralysis, would you aspirate? Or the kid will aspirate? Yes. That's why aspiration, why he cough and have weak breathing cry. Why is that? Because it's paralyzed. It doesn't mean, Now, and if you see the course of the recurrent laryngeal, which comes from the vagus, you understand. It's a long course that you understand why anything in the brain stem or central, or when they come to do BDA ligation and you see the aortic arch, why they could injure that one. So this is, you will see it. Unilateral stridor after cardiac surgery, PTA ligation, left vocal cord, it's a vocal cord paralysis. An infant with Down syndrome presents with respiratory distress and biphasic stridor. So it was inspiratory, then actually it's expiratory. So it's severe. When they said biphasic, means that really there is a good obstruction there in the newborn period, since he was born. Which of the following diagnostic evaluation will provide a definitive diagnosis? And here is the question. Because sometimes you come to two options, and we're talking about definitive, not next step. This is different in the board, because if I'm asking you for next step could be, this is a Down syndrome, something else I could be doing. But definitive means that you have to go for the kill. What will make you diagnose this kid? Go ahead. Very good. So in the upper airway, you have to visualize it, correct? And so what's your diagnosis? Congenital subglottic stenosis. Now, is the second most common cause of stridor. I want you to remember that. When you have we said laryngomalacia is a primary. It's congenital. Subglottic, there is some primary, but most of it is secondary. These are the kids who are preemie, or the kids who are intubated more than 10 to 14 days in the hospital. Why is that? Why intubation will cause subglottic stenosis? Because the narrowest point in the upper airway is in kids' airway, less than the age of 10, is the subglottic area. So when they tube them, That's where, if any friction can happen, that friction will happen in the subglottic area. And that will cause inflammation. Inflammation, if that goes for 10 days, our body always replaces chronic inflammation with fibrotic tissue, and that will give you subglottic stenosis. That's why we try to avoid it. That's why when you go in the ICU or the NICU, they say, how long this kid has been intubated? Has been intubated for 2 weeks. You know what? Maybe we have to consider tracheostomy tube before that will mess up his airway, and we're talking about subglottic stenosis. So if you get that scenario, a preemie, kid was intubated, and he, usually in the second week, he start to have, they extubate him, he's stridulous, then you say, oh, this is subglottic stenosis. That scenario goes with that. If it's a mild subglottic stenosis, and you don't need to know that, we stage them, we size them from grade 1 to 4. 4 is pinpoint, very severe. So if it's 3 to 4, they will be really stridulous and have respiratory distress. But if they are mild, you're creating an obstruction with increased resistance to the power of 4, and that will make you have this a stridor or maybe a little bit of it, but what's there, every time they have a cold, it will narrow it more, increase the resistance, and they become croupy. So if you have a kid who have recurrent croup, or he could have a mild subglottic stenosis. And then you go back in the history to see what could cause that. Is that clear? So, and then you need to see it. CT, X-rays, it's very, will be very blurry. It's like soft tissue, bone next to each other. No, you need to see it. So direct laryngoscope, the percentage of stenosis estimated, as I said, and usually if you have more than 50% stenosis, then you are symptomatic and you will need a treatment. Treatment from you dilate it to do cricoid split. That was in the first question. Because when you do that cricoid split, you will induce some opening of the larynx. So if I have a case, this is a kid who's a stridulous or has a stridor. How I think about it? Laryngomalacia is the most common. Common is common, but rare is serious. Oh, yes. How it changed? It changed with crying, supine position. When he has a cold, this is typical because subglottic stenosis is a fixed obstruction. It will not change with crying because crying is sympathetic, but it's not going to have, it's not a dynamic obstruction. Is that making sense? So when they say with the crying, you got your hint. Okay? So, and then it's in the wall of the larynx, so there is no involvement of the vocal cord. You have a normal cry, no hoarseness. If you have subglottic stenosis, it's a fixed obstruction. As I said, it's normal voice, but it does not change with that, with the crying. You could have also recurrent croup, depends on the severity. If it's vocal cord paralysis, oh, how's the kid? You see muffled voice. Oh, weak cry, aspirating, bilateral, go central, unilateral after trauma, cardiac surgery. Did he have a traumatic intubation, whatever? So that's will cause. I just passed the break. I don't know why it's break. Okay. So now we go to the acquired causes of stridor. We'll talk about croup, epiglottitis, bacterial tracheitis, then we'll go bronchiolitis and pneumonia. Croup. 18-month-old presents with, to the emergency department with a sudden onset of barky cough following 2 days of runny nose, cough and low-grade fever. Physical examination, temperature 98.1, heart rate 160, respiratory rate 40, saturation 94. Which of the following is the most likely diagnosis? And next. Very good. So I want you to remember this. You did not put a croup. I mean, if it's croup, it's croup. But a croup is what? Laryngo-tracheo-bronchiolitis. Remember this, because in the exam, there is a bronchiolitis there. Okay? So you should have, when the virus, the parainfluenza virus hits, it will cause laryngitis. But it also could go to cause a trachea and bronchiolitis or bronchitis inflammation. So you may have wheezing. Because, wheezing, then you go to RSV. If you have laryngitis, if you have a croupy cough, Don't get it confused. What's the most common? Then you go to RSV instead of parainfluenza. So remember this, laryngotracheobronchitis. That's the answer you gave me. So what's the most likely? I answered myself. What's the most likely agent for laryngotracheobronchitis? Excellent. It is here, and this is where it comes. Can influenza, parainfluenza, adenovirus, respiratory syncytial virus cause a laryngotracheobronchitis? No doubt about that. These viruses hit the airway. By the way, think about bacteria. Bacteria usually localized infection. It causes pharyngitis. It causes UTI. Viruses hit everywhere, random hitting. You got a cold, you are vomiting with it, you have gastro. So viruses could hit anywhere. Truly, this is how the viruses act. But here's, I think, maybe why some missed it. Most likely he's asking you what's the most common cause for it. Can all of this cause it? Yes, definitely. But the most common cause, and please don't forget it, because this is, you will see it. Parainfluenza 1, 2, 3. Parainfluenza. Say it as much as you want, but don't forget it. So it's the majority of cases. So that's why the answer, the most common they're asking you. So that's why you have to be careful what they're asking for. As I said, influenza, definitely. Adeno, definitely. Measles even, other viruses. Any virus can cause that. Most of the good number of viruses, let's to be right, could cause that. But parainfluenza is the most common one. Epidemiology, 3 out of 100 children will have it, more common in male than female. I don't know why. Most commonly present between 3 months to 3 years. And this is why. Remember? We said larynx, most of the growth, the progressive growth of larynx happen in the first 3 years. So if you have to narrow, yes, it's an infection, but we will not test for it. That's why we're not finding it. But when they come to crew below the age of 3, you say, oh, this is the age most affected. Maybe we are not. Maybe it comes, parainfluenza after the age of 3 may come as a cold. And you or you're going to send for parainfluenza? You're not going to do it. So you remembered, I'm giving you things to connect. 3 months to 3 years, peak incidence is the age of 2. Peak September to December in the Northern Hemisphere, and correlates, that's the cause, so it correlates with their prevalence of parainfluenza. Now, and this is important when they give you the history, because now I said the group, then I give you a question about the group. So it's easy. But in the board, it could be like, well, there are many things. So usually there is some URI symptom, but maybe not fever. Viruses may not cause fever. Barky cough, hoarseness, because now this is different. Laryngomalacia is weakness of the walls of the larynx. This is infection of the larynx and everything in the larynx, correct? So if your vocal cord got inflamed, you will have hoarse voice, correct? Stridor abuse 1 to 2 days later. The peak, and this is, I'm going to tell you why this is important for your practice even, and the board, 3 to 5 days, and resolve over 7 days. Now, if you are in the ICU, and you have a kid who's intubated for croup, very severe croup, intubated, the intensivist and the pulmonologist, they will come and say, day 5, let's see if there is a leak around the tube. And if there is no leak around the tube, we got stressed out. Because we know by day 5 that the croup should improve. And then if the inflammation decreases, then you should have a leak around the tube. And if you don't have a leak around the tube, means that this is bad, and this could go to, in the 2nd week, subeglottic stenosis. So it's a practical point. So you need to know natural history of these kids, because that's what your practice is going to be. I mean, you may not be in the intensive, but you will know that. So that's why day 5 we go, and when they said, oh, there's a huge leak, say, oh, ready to extubate, because we know by day 5. And that's why when they come to present to you as a pediatrician to the emergency room or the doc, which day of sickness? He have some inspiratory stridor, barky cough. This is a croup. Which day? Oh, this is a day 1. It's going to be 2 days later, 3 to 5. So we may not see the worst of it. I have to be ready. Either bring him back in 1 or 2 days, correct? To see him back or admit him if his age need admission. Whereas which day of the sickness is this? Day 5. I don't need a follow-up. I mean, call me if there's a problem. So that's where this is important for you. Is that making sense? So symptom worsen at night. Why at night? Nights are colder, correct? Cold weather induce bronchospasm, by the way. That's why they say spasmodic cough. There's spasmodic stridor. And why with agitation? When you get agitated, like crying, you start to bring a lot of not negative feelings, but negative pressures in your lungs. And that will bring in inside the airway a lot of negative pressure that will collapse them and cause that a worsening of. So you keep them not agitated. The physical exam depends on the obstruction. A stridor, and usually we will say, listen to the kid, is that stridor at rest? Because if it's stridor with agitation, it's not bad. You have to evaluate the kid and you need to admit him, but it's not bad. But if it's at rest without agitation, biphasic, admit him. Because we said agitation bring it, and he's at rest and he has a stridor. So stridor and bronchial cough, you will see retraction. You will say also in the board that comes to you, oh, I understand, he's a Kruby, so it's larynx, he could have suprasternal retractions. But why the intercostal retractions? The intercostal retraction because it is laryngeo, tracheo, bronchiolitis. Okay? And then diagnosis is clinical. Do you need to do any test for a group? Do you need neck fill? No, it's a clinical diagnosis. So then when you get a soft tissue X-ray or neck X-ray, if you are in doubt, the history does not fit. Unfortunately, patients does not read the textbook before they come to us. I hope so. They don't. So if you have an atypical, you think it may be a foreign body, maybe something else going on, you will do it and you will see the steeple sign. And then here you see the narrowing of the larynx. There is ballooning of the supraglottic area because usually they describe it to you instead of saying the steeple sign, and you get confused. You could get confused. So there is obstruction. You try to breathe in, so that will make, if there is obstruction, that will balloon your supraglottic. So they say there is ballooning of the supraglottic. Oh, nobody talked to us about this. This is a group. You're just describing to you the steeple sign. And sometimes they said in the X-ray, there is increased perihilar thickening, which is airway inflammation, which is bronchiolitis, by the way. So you support them. You keep the kids comfortable. Avoid agitation. I think we all keep the kids comfortable. We are all pediatricians. It's by choice. I hope so. If they need oxygen, give them oxygen. Before, in my old days, they will put them under the tent. They will die and you will not see them. So it's a controversy just for the board, but don't do it. Now, you could give them, it's inflammation. It's viral-induced inflammation. You can give them a dose of dexamethasone, PO or IV or IM, one dose. You could give them budesonide. They go sometimes to up to 2 milligrams once as inhaled steroids. There is inflammation, anti-inflammatory, like dexamethasone or inhaled steroids could help. You could give them racemic epinephrine, nebulized epinephrine. 1 in every what? The dilution? 1 in 1,000. Please remember that number. They will put you 1 in 10,000. 1 in 1,000. Remember that number. And if racemic epinephrine works for 4 hours, so if you do for 4 hours and it rebounds before 4 hours and you give him another one, you will need to bring them because of rebound symptoms. Is that making sense? If everything failed, you could do Halox, which is helium plus oxygen, just to help the obstruction. You could put them in CPAP, but I think this is beyond you. But remember, if all the standard care fail, you do have the Halox as an option. Croup, remember in the question we said high-pitched barking cough and stridor. We talked about this. Most common cause is parainfluenza. I said it a lot. And this is important. Racemic epinephrine may prevent admission, but does not change. Rest epinephrine does not change the course of the illness. Highlight that. So because think about it. Rest epinephrine decreases the inflammation or bronchodilate. It has some, and it could dry. But this is temporary thing because the inflammation is a virus, and the virus is ongoing until the virus by himself said, I'm done. That's what we do for most of the viruses. They're done by themselves, correct? So this is something may bring it down a little bit, but does not change the course of the illness. And remember that, I said it. Stable sign, rest epinephrine, and this is the dosing of the dexamethasone, 0.6 to 1 milligram. POIM, IV. Okay. 8-year-old presents, and if you have a question, just write it down. We have an hour and a half of lunch. I don't think that you will eat for an hour and a half. I hope so. I don't hope so. A 4-year-old presents with acute onset of high fever, toxic appearance, and complains of a sore throat. So his high fever, toxic, sore throat, arrived to the emergency room, anxious, irritable, an exam, respiratory distress with stridor, muffled voice, and drooling. What's the most appropriate? Look, the question said next step. So, very good. So your diagnosis is epiglottitis. So you need to look at it, make the diagnosis, and be ready in the OR to stabilize the airway and intubate. Let me go over the question, and I will. So a 4-year-old, it's a 4-year-old, high fever and toxic. Epiglottitis, they have high fever and toxic appearance. They have a stridor, but their stridor is not that loud or that bad. You know why? Because the epiglottis sits in, he's rich. He sits in a big room there, correct? So narrowing the area is not that much, even if it got inflamed, correct? So that will give you, if we look at bacterial tracheitis, trachea is limited room, so that will be more prominent stridor in bacterial tracheitis. I know I'm jumping, but I need you to compare. Whereas here, epiglottitis, there is a big room around it, so a little bit of stridor. Now, how many muscles involved in swallowing? 27 muscles. The epiglottis is but one of them. So if you have inflamed epiglottis, remember, it's the one who closed the pipe so the food will not go to that pipe, which is the trachea when we swallow. So it is part of the swallowing. So you will remember it. Epiglottis is part of our swallow. It's one of the muscle of swallowing. So if it's inflamed, you can't swallow. And if you can't swallow, even you are at risk of aspiration of your own saliva. You try to lean forward and roll it out because it's painful and you don't want to aspirate. So when you see drooling, think of epiglottitis. So true pediatric emergency. Uncommon since we have the vaccine for the Haemophilus influenza type A, B, but unfortunately we have the non-typable. They are smart. It's infection of the epiglottis, supraglottic airway caused by Haemophilus influenza, but caused by Streptococcus pyogenes. Staph also can be implicated. And that's why the non-typable comes first, then strep and staph. 0.3 cases per 100,000. And as I said, croup, they have URI before it. It's a stridor. Maybe it's a viral fever or no fever. This is bacterial. So you have more rapid onset, and they are toxic appearance, and they are drooling. That's why the head thrusts forward. That's why the tongue is protruding. And if you do X-ray, shaded thumb sign, this is how it looks. As you said, we need to directly visualize it, see it, and then you can see the thumb sign. Bless you. This is an acute airway emergency. You have to tell them, the emergency team, to be ready, taken to the OR, where you will look, because if you touch it, it may swallow more, and there is no room for swallow more. and then you will have obstructed airway. So you will have to be ready to intubate. And then you cover your antibiotics. It's a gram-negative, correct? Even Hemophilus and non-tival is gram-negative. So ceftriaxone, you could start with it unless you have a suspicion of other bacteria. When we come to bacterial tracheitis, the most common cause of acute upper airway obstruction after the age of 2. After the age of 2. By the way, Haemophilus influenza, usually this is what we call a, these are the bacteria, encapsulated bacteria. Usually they are more common in the first 2 years of life because our immune system is not mature enough in the first 2 years of life. That's why we vaccinate very frequent in the first 2 years of life. Whereas staph, no. So you remember, is that making sense? How many doses of Haemophilus influenza we take below the age of 2? Because our immune system is not ready to take care of encapsulated organisms like strep and Haemophilus. So that's where you remember Haemophilus influenza below the age of 2. That's why we vaccinate very frequent, but after the age of 2, staph and others could come. The mean age for year of age between 4 months to 13 years, and as staph is the etiology. Staph is the etiology. So you need to cover for staph, though Streptococcus, Moraxella catarrhalis also is could be included. So they come with fever. Look, they come with fever in epiglottitis. They come with toxic appearance, both toxic appearance. Here it's a barky cough. You remember what I said? It's less prominent. Even if they said no stridor, does not rule out epiglottitis. Remember the room. Who's rich and who's poor. Who's in a limited area. A stridor, and it could progress quickly to a respiratory failure. Okay? And there is no drooling. Did I say drooling here? Upper trachea is not part of our swallowing. I hope so. I hope not. Because if it's part of our swallowing, we will be all aspirating, correct? So upper trachea, no drooling. You see, there is no drooling there. You monitor them closely. You may require, because we said it may progress to complete obstruction and respiratory failure, you may need to intubate and ventilate. There is a lot of secretion because there is inflammation of the upper airway. You will need to section and move these secretion, and you give them nafacillin, oxacillin, anti-staph, or maybe third-generation cephalosporin in a high dose because it has anti-staph. And if you think, if they start to have a respiratory failure, multi-organ involvement, and really the kid is not doing well, you may do Vanco. Remember staph, how you treat staph. Okay? A 6-month-old exobrimi present to your emergency room with tachypnea, retractions, wheezing, poor feeding. She had a URI symptom with low-grade fever and runny nose for 2 days. No stridor, we're done. The scenario is typical for which of the following infections? Croup, epiglottitis, bronchiolitis, foreign body, aspiration. Very good. So there is no stridor. I was not kidding. There's a bronchiolitis. So that's why when the A is a croup, I said the croup is the symptom. What's the sign? Stridor. So when somebody comes to you with a croup, then when you present his physical exam, you say he has a stridor. I'll be waiting for you to say stridor because stridor is the sign. So he did not mention in their exam or in their presentation there was no stridor, so it can't be croup. If you don't have the sign, I mean, maybe it's not bad to be because it's stridor, but it's not. So bronchiolitis, very good. It's inflammation from the name, inflammation of the bronchioles. Virally induced or viral induced bronchiolitis. No airway spasm. So if you come and ask me, why, Dr. Manna, they are a bronchiolitis and asthma? What's the difference? Because asthma is a chronic airway inflammation. Yes, bronchiolitis is acute inflammation. I give it to you. Both are inflammation, but this is, though they are different type of inflammation. Asthma could be neutrophilic or eosinophilic inflammation. This is viral induced inflammation. The difference between asthma and bronchiolitis, essentially in bronchiolitis, no spasm. So what differentiates asthma from other diseases is the airway hyperreactivity, is the spasm. So that's why the American Academy of Pediatrics came and said, don't give them albuterol. This is not a spasm. If you have a spasm, you talk about asthma, reactive airway disease, whatever you call it. So essentially, should be no spasm, so no need for any albuterol or beta agonist or any bronchodilator. Is that making sense? There is no spasm in bronchiolitis. Usually results of a viral illness, and this time it is RSV. If you go back, croup, parainfluenza, RSV. Believe me, it's a given question. It should be a gifted question, but sometimes we got, you could mix up, especially there is an element of bronchiolitis in croup. So primarily affect children between birth, 24 months of age, peak incidence 2 to 8 months, winter months. I mean, we know the RSV, we start thinking of giving them by September, August, depends on the epidemiological data. RSV could affect any season, by the way. But there in the health department, they will be checking the prevalence in certain centers. If it goes more than 20%, let's say the prevalence, they say the season started. And then they keep checking it until it dropped below 20%. The prevalence then say the season's end. But can occur, as I said, it can occur year round. So you have 1 to 4 days of low-grade fever with a clear diffuse rhinorrhea and congestion. What you remember, I'm sure you saw a kid with a bronchiolitis. A lot of secretions. This RSV, I call it the secretion guy. Because really what they need, suctioning. And that's what causes runny nose, a lot of runny nose, a lot of suctioning. That's what causes hypoxia, the inflammation of the airway, give you VQ mismatch, and mucus plugging more. I mean, they mucus plug a lot, and that's why we watch them. So remember that. And it's similar. They peak around day 3 to 5. The RSV, metapneumovirus follow that too. But there's other viruses which causes a bronchiolitis, which causes bronchiolitis does not follow that. 3 to 5 could be mild, moderate, or severe respiratory distress. And the cough, they could be tachypnic and wheezing. Why wheezing? Bronchiolitis is airway inflammation. You narrow the airway to the power of 4. So you see that equation was not for nothing. So it's you narrow the airway, you have turbulent flow, you wheeze, and you cough because there is inflammation, and you and also you become tachypnic. So they have poor appetite and feeding. Kids do that, and if they breathe fast, they may choke, cough. You have to be careful with that. They could be lethargic. They may not stop eating, and they develop a dehydration and drinking and become dehydrated. This is, I can't help you with that. I can explain these. I try, there's some, they have explanation now. So risk factor for severe bronchiolitis, just look at them before the board exam. Family history of asthma. I can explain that, but I can't explain all that. Family history of asthma, I think why it came, because this is epidemiological data. This is descriptive. Nobody till now can, but I believe that family history of asthma, because you are born, because asthma is a clinical diagnosis, but there is a genetic and environmental factor. And we know that kids who got bronchiolitis, before we thought it's only RSV bronchiolitis, now we know any bronchiolitis, not URI, these kids will cough and wheeze for months and years after. That's what they called in the past viral-induced asthma. So most probably if you have the genetic, that RSV could trigger it. And that may be why it is a risk factor for severe bronchiolitis. At least think about it this way when you see it in the school-age siblings, more infections, lack of breastfeeding. I mean, you will not go wrong if you said that, yes. Correct? Anything given breastfeeding, we promote it, then lack of breastfeeding, 2 or more individuals sharing a bedroom, multiple births, passive smoking, yes, smoking is bad. Anything have breastfeeding is yes, anything smoking, say no. Low birth weight. And low birth weight. Low birth weight also, by the way, one of the risk factors for asthma is prematurity and low birth weight. So you can tie it. So there. So you have in physical exam low-grade fever, respiratory distress, tachypnea, and wheezing and crackles. Diagnosis, as I said, it's completely clinical. So you don't want to be, it's a clinical diagnosis, no swabs, no viral tests, nothing. Now, nothing. Say, oh, so I will not admit him. Nothing. It's a clinical diagnosis. You do nothing. You just clinical diagnosis, as we talked about, and you take it from there. As I said before, they said the RSV could cause reactive airway disease, but we found that rhinovirus, when it causes bronchiolitis, it has even the same effect, so it does not matter. So I will explain to you the symptoms. So when you have, we said bronchiolitis is inflammation of the small airway. If you inflame the small airway, you can't exhale everything out, correct? Because they are not, their airway intrathoracic, narrower, and expiratory phase. So you will air trap. So that's why you got the hyperinflation. Now, when you have your airway, they are a tree upside down. When your airway wall is inflamed, it will give you the peribronchial thickening. So now, and then because of that thickening and bronchioles got clogged with the mucus and inflammation, you got microatelectasis, which look like diffuse interstitial infiltrate, and you could have a big collapse if there is a big, large airway obstructed. So that's explanation for what you see in the X-ray. It could be normal in 10%. So if you have, that's why we don't need a chest X-ray in bronchiolitis, correct? It's a clinical diagnosis. But if somebody did it, that's what you see, because they are normal in 10%. What could predict the severity? Toxic or ill-appearing. This is important, remember, because usually it's less than 92 or less than 95, your oxygen saturation, less than 95. Remember that? Don't remember me, but remember that in the board. This is 95, so this is a predictor of severity. They will give you a whole case, and they tell you the SATs are 93. So you will think this is going to be a mild or moderate or severe. 95. 95 is the number, because usually we add oxygen if it's less than 92, correct? Then that's always your thinking, like that's the mainstream thinking, but 95 here. Gestation is below the age of 34 weeks. That goes with prematurity and low birth weight as risk for asthma. Kid breathing more than 70. If there is atelectasis, meaning that this is really big, and there's a lot of inflammation that you cause mucus plug-in inflammation, you produce a collapse, less than the age of 3 months, that could be understandable, but the single best predictor is oxygen saturation. Remember that. If you remember it, you get a question right. You'll get a lot of questions right. So what's the most common problem in bronchiolitis? Hypoxia. So if I tell you, or they ask you, what could be a kid, when you admit him for bronchiolitis, you admit him to supportive treatment, but it's also to watch for hypoxia, because there's a VQ mismatch because of the airway inflammation and the mucus plug-in and maybe atelectasis. So hypoxia, oxygen. You correct dehydration, there is no albuterol epinephrine, no steroids, no antibiotics. But they give you this scenario, and this is, you'll see it I'll tell you, you'll see it in the board. You may not, but you will see it. The 3 things, no antibiotics, this is a virus. So I give you a case. If I am with you in the hospital, you call me, say, Dr. Mani, this kiddo has day 5 of fever. He improved clinically, but day 5 of fever, and it's a high fever. What's the next thing you have to do? Check his ears. The most common complication of otitis media is ear infection. So check his ear, and that if there is otitis media, give him antibiotics. So that's one. Then they give you on the board, there is no otitis media. So what's next? Oh, do a chest, listen to the kid. There is crackles. Oh, this is consolidation, atelectasis consolidation. So secondary bacterial pneumonia. That's the second. They tell you on the board, normal chest X-ray. They will ask you, what's your next step? UA. There is association between, and I could not explain it, and I looked in the literature. So far, there is association between RSV, bronchiolitis, and E. coli UTI. So when they ask you next step, if they tell you first is ears, don't jump to the UA. Ear, chest X-ray, then get a UA. So most common causes RSV. Most infants are infectious for 7 days, but some shedding for months. This is a common question, and you may see it. And a practical question for you, also for your practice. Kid got admitted with RSV bronchiolitis. Unfortunately, they did the test, came RSV. Admitted him for 5 days. This went home after a couple of days, came back after 3 weeks with some URI symptoms. They did again the RSV test. Why are you doing it? I don't know, but they do it. And then still RSV. And then what they will say, we need a consult for immune deficiency. There's no consult for immune deficiency. This is RSV, and these kids could shed the virus for weeks or months. So don't test them. It's a URI with whatever the virus is, but don't test them. There is no rule for ribavirin antibiotics even, and this is important, in the RSV immunoglobulin, you give it as a prophylaxis. And this is, you have to remember this, because they put it there. You do not use it for acute management of bronchiolitis. Because in the board, I said, you start thinking, oh, it's antibody. Who will, we give IV immunoglobulin for diseases or viruses, so why not? No. Don't give RSV immunoglobulin in acute illness, only as passive prophylaxis. And the dispersion is particle and contact. Remember the contact. I'm stressing on contact here too. So the scenario could be that, oh, this kid also, it came to your hand and you rub your eyes. It is contact. Can be RSV bronchiolitis because he rubs it. Yes. So it's a contact and respiratory isolation. Contact, could be spread through it. No steroid, no antibiotics, no bronchodilators. There is some, but that's not for you when we use it. So RSV prophylaxis should be initiated prior to the onset of the season, which makes sense. It's a passive immunity that lasts for 4 weeks, correct? So before the season, then you continue until the season is end. And that's also another question. Oh, this kid has RSV bronchiolitis. He is immune, and he should not get the RSV prophylaxis. Immunity for RSV is not live immunity, not live-lived immunity. It just as much as could be the RSV immunoglobulin prophylaxis. So you need it. It's not protective for subsequent exposures. Now, there is a recommendation that came 2012, and then the recommendation got also rectified 2014. What changed that the risk factor, and I will explain it simple way. Risk factor, attends childcare, one or more sibling less than the age of 5 years living with the infant. So remember these 2 risk factors, okay? So that's actually, if you look at it before, if you forget, just have a look. There's things that you have to look maybe a week before the exams, and I'm telling you what they are from pulmonology. So kids eligible for maximum of 5 doses, less than the age of 2. We did not say in the first year, 2. So you can give it up to the age of 2. And this is important. With a chronic lung disease of prematurity, requiring therapy. So any kid who's in oxygen, still in diuretics, or in steroids, and he's a premature baby, have a chronic lung disease of prematurity, then you give it 5 doses. Or hemodynamically significant congenital heart disease requiring therapy, diuretics, oxygen, whatever therapy he is on. So these are the indication for 24 months. Now, we don't need risk factors if you are below the 28 weeks and 6 days. Below 29, you don't need risk factor. Remember that. This is the change. So with no risk factor needed. Okay? Highlight that. And then there's certain cases with the neuromuscular diseases, because they have neuromuscular, they have a weak cough, so they have a lot of secretion. And we said what RSV is? The secretion guy. You don't want to give the secretion guy to a kid who have a neuromuscular weakness or disease. He can't clear up his secretion, and then you challenge him with more secretion. So that could justify giving the RSV immunoglobulin. Eligible for 3 doses, gestational age 32 weeks to 34, and 6 days with at least one of the risk factor, and born 3 months before or during the RSV season. So the risk factor needed between 32 to 35, and born during or before 3 months before. Do you see anything between 28 and 32? Okay, remember that. Okay? So the update was lowered age limit from 31 weeks, 6 days to 28 and 6 days if otherwise healthy. No risk factors, as I said, taken into account for the need. Now, pneumonia. So we're doing good. So before I go to pneumonia, I'm gonna tell you how I approach pneumonia. Then I will fill in these bacteria. When I face, and this will help you in your board and your practice. So for me, when I see a pneumonia, I ask myself, as a pulmonologist, is this a typical pneumonia or atypical pneumonia? Then also, I take the age. So I can decide the choice of antibiotics, what I'll do. So what's typical pneumonia? Typical pneumonia, you go from symptoms, signs, X-ray, and blood work. So kids have high fever. Kids have coughing, pleurisy, chest pain. In the exam, there is localized crackling, crackles. I did a chest X-ray, it is consolidation there. I did a white count, it's more than 15,000. So this is typical pneumonia. Typical pneumonia means it is a pneumococcal pneumonia, or staph, or other bacteria. Now, atypical pneumonia, and I'll tell you what's the agents there, or the organisms, the bugs. Atypical pneumonia, a little bit of cough, plus minus fever. You look at, you find bilateral crackles. You do a chest X-ray, what they call walk-in pneumonia, bilateral perihilar, or a bilateral infiltrate in the X-ray. You do the white count, either normal or leukopenia. And the most common cause for atypical pneumonia is a mycoplasma, chlamydia, and viruses, don't forget. Now, I want to just give you, since with our age, we remember things that help us to remember. Otherwise, we have dementia sometimes. So in the past, they thought that chlamydia and mycoplasma are viruses because they are intracellular. They go inside the cell. That's why, if you have a virus, why do you think that when you do white count in a viral infection, what happened? It's leukopenia. You know why? Because viruses goes inside the lymphocytes or inside the white PCs, and then it divide and burst out and kill that white PC, correct? Then it will cause leukopenia. Bacteria, they are soldiers, and they fight without going inside the cell. So that's why we have leukocytosis in bacteria, leukopenia in viruses. So it was behaving like a virus. So they behave like a virus. That's why they have not that much of fever, not that much of symptom, and usually it's bilateral. Remember what I said about viruses? They hit everywhere. They hit the both sides. Those strep pneumonia could cause also both sides diseases, but this is at least. Now, the picture, as I said, patient does not read the textbook. It's not as clear cut as this. So they could come and confusing between typical or atypical. So if you are confused, then I take the age. So I divide them, and we'll go over this. I divide them from 0 to 4, and to 4 to make it easy to remember. 0 to 4 months of age, what? Rule out sepsis. Early sepsis or late sepsis, correct? Neonatal sepsis. 4 to 4, so 0 to 4, 4 to 4, 4 months to 4 years. The most common, if you have in the question, in the board, they said, a 3-year-old coming with fever, cough, and you have crackles. The most common, what's your drug of choice? The most common between 4 months to 4 years is pneumococcal, bacterial. The more common than pneumococcal, viruses. Remember the bronchiolitis we just talked about? This is viruses, influenza, parainfluenza, RSV. So viruses, then pneumococcal. After the age of 4, through adulthood, it's atypical, it's mycoplasma and chlamydia. So if the question in the board said that 12 years old with pneumonia, and they stop, 12 years old with pneumonia, what's your drug of choice? Macrolides. Azithromycin. I like azithromycin. Macrolides. Because by age is the most common. That's why in adult practice, they have it easy in pneumonia. They don't have to think about it. Adult, give him azithromycin. That's why they're giving azithromycin left and right. But for us, so I divided these 2 ways, by age, by also presentation, and then we'll help you through. So let's fill in these. So diagnosis is difficult to make in very young, because that's why when you have a kid who's a newborn and have sepsis, you do a chest X-ray, though you don't have any finding, correct? Any localizing signs or signs, you say it's part of the sepsis workup. What you're telling me that is pneumonia, difficult to make in very young kids. That's why you do X-ray in any rule-out sepsis. Correct? You do it, correct? I hope so. A clinical guideline established to help with the diagnosis in children more than 2 months of age. So tachypnea, subcostal retraction, cough, crackles, decrease breath sounds because if they develop a fusion, You know, the pleura is a very nice friend to the lungs. Sympathize with it. So every time it got inflamed, it inflamed with it and got a fusion with it. It does not get inflamed, but what we call a sympathetic effusion. So it really sympathizes with it. That's what good friends are for, correct? So that's why you got the decreased blood sounds. So you most likely have pneumonia. You could have fever, and although not as specific, but if you don't have a fever, become less likely to have a pneumonia. But don't forget the atypical pneumonia, they may not have a fever, but it's become less likely. So fever is important there, and it depends. I'll be honest with you, not for the board. In general, you have, in the United States, our pneumonia diagnosis is a radiological diagnosis, by the way, because we can get X-ray. Whereas the definition from the WHO, it's a clinical diagnosis because they don't have X-ray. So, but use these. So you know that every degree of fever, you increase your heart rate by 10. And you increase your respiratory rate by 3 to 4. Remember that. So you will be tachypnic with a fever. So you have fever, high white PCs, and we're talking about here the typical. I'm sorry, go back. So when you need a chest X-ray, you need a chest X-ray if you have a kid who have a fever, high fever, comes with a fever, white PCs count more than 15,000 or high, and you don't have a source. You say, you know what, I was told that pneumonia is difficult to diagnose. I may not be hearing anything in the chest. Let's get an X-ray. Or, I don't know, it seems like a pneumonia. It could be a pneumonia, but let me get an X-ray on it. Or if there's a fusion. If there's a fusion, this is a localizing sign, correct? There is a fusion, so you have to get a chest X-ray. Or if you think this is a clinical pneumonia, you say kid coughed a little bit, or I diagnose him with pneumonia, but he's not improving. His fever has been more than 72 hours of antibiotics, and he's not improving. Then I'll say, okay, maybe something else going on this kid. Let me get an X-ray. Is that clear? So they make sense, correct? When you get a chest X-ray. So as we said, the features depends on the organism and the bug and your host factors. Is this immune competent, immune deficient, or this is a kid who's malnourished, and the severity of the disease process, because it could be different. That's why I could get RSV a kid could get RSV bronchitis is bad, the other one is not, because of these factors. Signs and symptoms are seen, bacterial, atypical, and we will talk about them, but they could, as I said, the bacterial, the atypical, the viral could overlap. And you could get confused. And I have times, believe it or not, just to emphasize on this point, I have times seen a kiddo in the clinic who I could not differentiate if this is typical or atypical. I put them in both amoxicillin for pneumococcal as typical, and I put them in azithromycin together. And this is justified. And if I suspected a staph, I put them in augmentin if I got more confused. So we get confused. I get confused sometimes. They don't read the textbook, I hope. Maybe now with the tablets, we give them tablets. Maybe textbook's heavy for the bug. I don't know. Is that making sense? So if you have bacterial causes, which means the typical, you have a high white PCs count, as we talked, more than 15,000, high fever, a blood culture recommended for inpatient setting with more severe pneumonia. I mean, they are admitted, and remember that. They are admitted because they have bad pneumonia, correct, and respiratory distress. It's a severe pneumonia that you admitted them. Usually the yield is not that high, but you will do it if they have high fever and pneumonia. Inpatient, not outpatient. If you declare a patient that needed blood culture and he may have bacteremia, then you don't discharge him, correct? So inpatient setting. And we don't test for a specific pathogens, not routinely recommended. If I have all the symptoms of typical pneumonia, I go ahead and treat it. So viral pneumonia, and this goes from 4 months to 4 years. Most common cause of pneumonia in children, viruses. So if you ask, what's the most common cause of pneumonia in children? Viruses. The bronchiolitis, the parainfluenza, we talked about all of them. We gave a lot of talk about them, so they are still there. And that's in the past, they call them bronchopneumonia. Bronchopneumonia because they involve the airway and the lung parenchyma. That's why the name, though it changed in the past, they would say, oh, he has bronchopneumonia, which is atypical pneumonia or viral pneumonia. Is that making sense? Then he said, no, make it bronchiolitis, make it this. preceded by upper respiratory symptoms, as we talked about in bronchiolitis. Rhinovirus could cause also bronchiolitis and pneumonia. They could have rhinuria, nasal congestion. So preceded by upper respiratory symptoms, they could have rhinuria, nasal congestion. Even rhinovirus could cause a pneumonia, followed by onset of low-grade fever, non-productive cough, tachypnea with wheezing or crackles here diffusely. So it's bilateral usually. As I said, viruses hit both. You have it's a bronchopneumonia. If you want to remember it this way, it's the bronchiolitis. So you will have narrowing of the airway, so you wheeze, and it's pneumonia. Pneumonia give you crackles. So, and the X-ray, if you have inflammation of the airway, you will see perihilar thickening. That's what they call perihilar thickening, by the way, just thickened walls of the airway. And because it's pneumonia, it's infiltrate of the parenchyma. And then you just support these. They are viruses, rehydrate them, give them oxygen if needed. And this is what I talked about, pneumonia by age. Here, 0 to 3 weeks, if I'm going to divide neonatal sepsis, 0 to 3 or 0 to 4, GPS, gram-negative, 3 weeks to 3 months, viruses, chlamydia, and strep pneumonia. Usually I do it 4 to 4, so I will not forget. But then 4 months, 0 to 4, months, from 0 to 4 months. Then 4 months to 4 years, the most common, strep pneumonia, then viruses, then group A strep, then staph. So pneumococcal. So if you have, as I said, if you have a 3-year-old who coming with symptoms of pneumonia, you can give amoxicillin, and there is no problem with that. If they did not mention what will help you to differentiate if this is a virus or chlamydia or mycobacteria. If they give you more symptoms to differentiate typical, atypical, then you also use this information. But by age, you can do that. 5 years and above, as I said, it's mycoplasma. Still, strep pneumonia could be a cause, chlamydia, but and then a macrolides will be a drug of choice. Atypical pneumonia, usually you will see it, as we said, you see we are, I'm sorry, it's repeating, but it's okay, it's okay to emphasize the point. So we said from age of 4 and above, it's atypical pneumonia. That's why we're saying it's usually more than the age of 5 years. No sputum production, not toxic, as I said before. Normal to slightly elevated YBCs could have normal or even decreased leukopenia, mycoplasma, chlamydia, histoplasma, coccidia, legionella. And I put these, I know infectious disease like this, but I put you this, Q fever, if they mention to you sheep or cattle there. So remember Q fever. That will be good. That's what you need. Coxella, Parniti, not transmit between humans. So if you tell you, what's the least likely, this the Coxella does not go between humans. I just put these. They are recall questions if there is a question, but remember these 2 things. Okay. Let's do this. A 3-month-old infant has repetitive staccato cough associated with tachypnea, intermittent wheezing since 3 weeks of age. Nasal congestion, conjunctivitis, occur with the first week of life. Positive family history of asthma. Physical examination, afebrile, wheezing, no retraction. Chest X-ray shows hyperinflation. What's most likely etiological agent? Excellent. Okay. So let me ask you. So this kid, when the cough started? Since the 3 weeks of age, correct? And how old is he now? So what's the 100-day cough? Which is the 100-day cough? Okay. And when you see a staccato cough, very good. Okay. So bacterial pneumonia, streptococcal pneumonia, as we talked, abrupt infection with fever, cough, tachypnea, malaise, and emesis. This is typical pneumonia. Remember, we talked about that. Physical examination, diminished breath sounds because of fusion. You have localized crackles. We already talked about this. Hypoxia, because a pneumonia is a VQ mismatch, correct? there is a sterile effusion because they are, as I said, they are good friends. Pneumonia, lungs and pleura are good friends, so they sympathize with each other, so they get parasympathetic effusion. If fever recurs and effusion is still present, you should consider, we'll come to that. So, and most probably this sterile effusion require no intervention, and they disappear as you treat the pneumonia, because this is just the pleura sympathizing with the parenchyma. If you treat the parenchyma, then everybody is happy and the effusion disappears. Okay? If the patient improved with the treatment, but they still have the effusion, and the fever came back, so what could be the problem? So if they give you that scenario, say this is a kid who came with a pneumonia, improved on antibiotics in day 5, he came back with a fever, and you listen to him, there is a decreased air entry there. What's most likely diagnosis in this kid? Empyema. Very good. So because you have fluids in the pleural cavity, which is good media for infection. Yes, it was because it sympathized with the pneumonia or the lung parenchyma, but also the bug could get an access to that fluid and get it infected and, and make pus in the pleura, which is the empyema. And then if that's the case, you need to either do a TAB, thoracocentesis, diagnostic, if they are in antibiotics, but also you may need to put a tube or do video-assisted VATS, video-assisted thoracoscopic surgery. It depends. But if a kid haven't had a pneumonia, some effusion, usually you don't need to do anything for the effusion. It is just a sympathetic pneumonic effusion, just that will disappear as you treat the pneumonia. But if the fever recurs after weeks, after days, and you still have effusion, you have to consider empyema. Streptococcal biogens. So this is the pneumococcal. We come to the streptococcal biogens. Causes pneumonia, usually after rash disease. So there is the history that comes to say the kid has scarlet fever, the kids have rubella, the kids had varicella, and now he has pneumonia. What's the causative agent, or which bug will cause that? When you see the rash, the scarlet, the rubella, the varicella, and pneumonia, the answer is Streptococcus biogens. They could have nematocele, but when you hear nematocele, think staph. Is that fair? And they are common, and nematocele, they disappear. They could take weeks, but they disappear spontaneously. So what's nematocele? I'll show you what nematocele is. A cyst or necrosis in the lung with a rim of inflammation. But when you see nematocele, think of staph. So most common complication, they could develop abscesses and empyema, and usually treat them. They are strep. You treat it with penicillin. Though we know that there are some resistant. In the old days, when you have somebody will have like strep throat or strep, you just say penicillin, the bacteria will die. Just say it. Now it's resistant, there is resistance, but still the drug of choice is penicillin. Anaerobes are rare in children. Sputum is usually it's really strong and putrid. A treatment with ampicillin and amoxicillin. Really, you won't see that much, but you have to keep it in your mind. So you can see nematocele even in pneumococcal, by the way, because we are seeing some resistant pneumococcal. But keep it in mind when you see nematocele, staph. Though I mentioned it with a Streptococcus pyogen, remember staph. Much less common, but have a very serious complications. Usually, there are two scenarios for staph they may give you. The first one is a year-old, young age, with toxic one, rapidly progressive illness. So these are the key points. One, around the age of 1, toxic looking, even if he did not start as toxic, rapidly progressive illness. That's why very serious complication. And then if they said nematocele. So that's one scenario. This is most probably a staph. You treat it as a staph. And the second scenario, and we see this in clinical practice, most probably you've seen it as residents and you're going to see it as a pediatricians. Usually we have that peak of influenza season, correct? 4 to 6 weeks after that, if they give you in that scenario, remember this. After 4 to 6 weeks of influenza, a peak season, we start to get staph, resistant strep, abscesses, or more of pleural effusion, empyema, and all these things. Why is that? So the second B. The reason for it, when the influenza virus comes, it wipes out all your cilia, or most of it. So you don't have a nice mucociliary clearance mechanism. So that's why these kids after influenza, they could cough up to 3 months. That's how much you may need to re-epithelize and make the cilia back. And they come, oh, he's still coughing. I'm not. He's still coughing because he tried to compensate with cough for the impaired mucociliary mechanism. But they also get some secretion retention, which is good media for the staph and strep. So that's why we see 4 to 6 weeks a peak of staph and strep then staph. So these are the two scenarios that may lead you into the diagnosis of Staph aureus. You can nematocele, pneumothoraces, abscesses, empyema are common. That's why it gives you, staph is nasty. It is complicated and you have to think about it. Now, I want to also mention here, and I'll come to it, think of this organism in patient with recent URI, especially influenza, as I told you, with fever, cough, tachypnea, and if it shows nematocele. So if you have that scenario, he was sick 4 to 6 weeks ago with this and that, and then you go. Treatment with nafcillin, vancomycin, or Clinda, if concerned MRSA. So I'll give you what's a scenario could come in your board. So a kiddo, MRSA is now community acquired, correct? There is MRSA, methicillin-resistant Staph aureus, which is community acquired. So if you have a kid and you think that this kid may have staph or MRSA, so the drug of choice is ceftriaxone and Clinda. So you add a Clinda if you think of MRSA. Remember that. You could, when you admit them with severe pneumonia and with such complicated pneumonia, and you think of MRSA, you may add Clinda. This is the nematocele, where it is necrosis of the lung parenchyma, by the way, what we call now necrotizing pneumonitis, by the way. It's part of it. And you see the rim of inflammation around it? That's a rim of inflammation there. Before we end, let's do this question. An 8-year-old male present to our office with complaints of fever, cough, sore throat. He has low-grade fever and is not toxic appearing. On exam, he has inspiratory crackles in the right lower lobe and enlarged spleen. Chest X-ray shows a fluffy right lower lobe infiltrate. The most likely diagnosis is mycoplasma. Okay, so staph, low-grade fever, not toxic, not sick looking. That's why I said not toxic appearing. Have crackles and the enlarged spleen. So remember what I said, that's why the history, it helps us. When I said we got dementia, but the history helps us to not to show it, though we hide it. So mycoplasma was considered like what? A virus, correct? So viruses hits, I said where? Everywhere. Mycoplasma full of the viruses. It abandoned the bacteria where it belonged to and full of the viruses. So mycoplasma could hit outside the lungs. They could have hemolytic anemia. Correct? They could have encephalopathy, encephalitis. They could have carditis, by the way. So mycoplasma acts like a virus. That's why we got confused. It's a virus or a bacteria. So when you see symptoms, extrapulmonary symptoms outside the lungs, think of mycoplasma. So mycoplasma, more than the age of 5. Remember we said above the age of 5, atypical pneumonia with the same symptoms. What I want you to remember this, there is discrepancy between clinical presentation and chest X-ray, as I said, they are mild, no high fever, nothing really that much. You do the X-ray, you see bilateral walk-in pneumonia, bilateral infiltrate. So, wow, this kid should be sick. You look at him again, he's not that sick. If I ask you, and there is extrapulmonary manifestation, and now you know it hits everywhere, and is it macrolized? Now, I'm going to ask you a quick question so you will remember, because I want to help you. I know you have 2 months before the board. I'm not sure if you're going to be able to review all this. But if I ask you, what's the single test, bedside blood test you can do to diagnose mycoplasma? I will answer because I have 2 minutes. So you get a CBC tube and put it in ice. If agglutinate, then you have 50%, most probably you have mycoplasma. This happened in 50. Why is that? Because remember, in the back in medical school, or maybe residency, they will say there is a cold agglutinins and there's warm agglutinins. So IgM, mycoplasma, give you cold agglutinins. And that's cold agglutinins antibody, the one that attacks the RBCs and give you hemolytic anemia, attacks the brain and give you encephalopathy. Is that making sense? So remember that to produce serum IgE antibody assay, it's a producer for cold agglutinin. And if you remember, they said ABV, CMV, and then with a cold agglutinin and leukemia and lymphoma, since you were in leukemia lymphoma session before me. And then after that, leukemia, lymphoma, and cold agglutinin and mycoplasma. So we're going to continue with the pneumonia. What's left is the fungal pneumonia. We'll touch base on these. What I want you to remember, what I said before, so fungal pneumonia, it's a atypical pneumonia. So it's not the typical pneumonia. It's atypical pneumonia, as we talked before. Not that much of fever, maybe asymptomatic, not that much of findings. So remember that. Now, when we talk about histoplasmosis, that there will be question about these fungal, but I want you to remember the area, because that could be the answer. Histoplasmosis is usually seen in Mississippi and Ohio River and Illinois River, because I come from Illinois, we see a lot of cases. The way we see them, actually, most of the time, coincidental finding. So that means that they are asymptomatic. So remember that Dr. Mann said they are just coincidentally found. We do a chest X-ray for any reason, and when we do that X-ray, we find hilar adenopathy or nodules. And most of the time, if they've been there for some time, calcified nodules. Okay? So when you see this, so that's why most of them, they are asymptomatic. And when you see something calcified, what that means? Your body already took care of it, correct? So that's where when you have a lesion, either you fibrose it, or you calcify it, or you put amyloid on it, like in Alzheimer, or in the kidneys sometimes. So when you see it, so if you see this in the chest X-ray, then you will say in this area, which is the Mississippi, Ohio River, and Illinois River, you say this could be histo. They are epidemic with it, so you may not do that much. You may check for it, and most of the time does not need any treatment. Usually, if there is symptoms, like this kid may get the chest X-ray for us. As a pulmonologist, he may get the chest X-ray because there is a cough. This cough could be asthma, could be something else. Then sometimes we get confused. Is this finding have anything to do? Most probably not. But sometimes we ask for urine antigen. And this is true for histo, coccido, plasma. We will come to it. If there is a antigen of this histo in the urine, then it's an active treatment. It's an active infection. Coccido, and remember the areas. If you forget anything, and I don't know how to make you remember these areas, remember me with the histo. I don't know if that will help. So, since it's Illinois River. So, Southwest United States, you will see the coccido. Remember that. Now, California is one of them, correct? So, the C. So, C and coccido, California. Remember that. So when you say California, around California, oh, yeah, C. Go for the C. There's no way. It's a recall question. So what you remember that frequent skin manifestation, so including erythema multiforme and erythema nodosum. Erythema multiforme is the one when you have the target lesions and you need to know how erythema multiforme minor, major, and all this. But remember, in the differential of erythema multiforme, coccido comes. Also, erythema nodosum, this is the painful rash in the lower legs and usually symmetrical. And erythema nodosum, one of the differential. Coccido is one of the differential for erythema nodosum. But remember these two rashes also with coccido. We diagnose them with complement fixation titers, and you treat with a fluconazole. If it's bad, ampho-B. But if not, these fungal the coccidia and the histo, they are self-limited and they resolve. But unless they are active, then we do that. And usually with the fungus, what I want to remind you, when they do construction in the hospital, what they do? Usually they really try to screen it off, to put something to prevent the dust from coming around. The same thing when they break the ground, because the fungus are in the ground. So when you break a ground, if they give you a scenario, there was actually in California an outbreak of coccido after a major work and breaking over ground. So it is in the soil. So when you play with the soil or you break a ground, that's when you have your fungus infection. And usually it's self-limited, and if it leaves coccido, if it leaves anything, it will leave after a lung infection, it will leave a thin walled cavity. A blastomycosis, Midwest, South Central, Southeastern United States. I wish I can help you except for California coccido. And Illinois me, so whatever else, look for it. So it's blasto. It's a mass-like infiltrate. With the coccido, with the O, remember with the O, you have a thin wall cavity, if you want to remember it that way. So C stands for California, the O stands for thin wall cavity. With the blasto, you have a mass-like infiltrate. So definitive diagnosis, when we say what's the definitive diagnosis, you need to isolate it, either from the sputum, it does disseminate to the skin, bone. That also could be a place or a location you may be able to isolate it from. So it could go there by itself, so you could isolate it from there. And here, the recommendation, remember the histo, the coccido, self-limited. If you have doubt, you may check for IgM, but you may check urine antigen. But all blasto diagnosed should be treated. So treatment is recommended in all patients diagnosed with a blastomycosis, with itraconazole or amphotericin B, depends on how bad it is. And there is more option, but remember that. So this is a recall question. I mean, I tried, but this is how So this is with the blasto, most common organ affected is the lung, 79 to 85%. You will see either a whole mass-like consolidation. So if you think of typical pneumonia, like a consolidation in typical pneumonia, but it's not a typical pneumonia. That's where I said sometimes there is overlap between them. That's why sometimes you cannot distinguish it from bacterial pneumonia, because it comes with consolidation. That's one of the signs or the characteristic that blasto comes with. Could be also this fluffiness, nodular interstitial infiltrate, the second and the third frequency. It could be like as if it snowed there, correct? If it was snowing in the lungs. Very fluffy nodules or interstitial infiltrate. And this is how it looks in the CT. So we'll talk about asthma, foreign body aspiration, cystic fibrosis, primary ciliary dyskinesia. Now, before I go into this, I'm going to highlight about asthma a couple of things, and you need them. Now, if I tell you asthma is one disease, is that correct or wrong? That's wrong. Asthma is a heterogeneous a group of diseases. Remember, what's common in them, it's inflammation and spasm. So there is two phases of asthma: early phase asthma and late phase asthma. When you get it triggered, you got the bronchospasm in the early phase asthma. If you get asked, what's the drug of choice for early phase asthma, since it's a bronchospasm, the drug of choice is beta agonist, short-acting beta agonist. Late phase asthma, after you get it triggered, you start, after 3 hours from the trigger, you start to develop airway inflammation. So asthma is a chronic airway inflammation. So the late phase asthma is inflammation. If you get asked, what's the drug of choice for late phase asthma, the answer is inhaled corticosteroids, not oral corticosteroids, inhaled corticosteroids. Singular could help, but it's inhaled corticosteroids. That's one. So the second, that's why when you go in the clinical practice, so you will remember it, you will have two phenotypes. They come to the hospital. Somebody all of a sudden, within a few hours, he has bad attacks, severe attack of asthma, come to the hospital. You give him more frequent beta agonist, albuterol. Then within like 24 hours, 12 hours, you turn him around, you send them. They don't even call us for a consult. And you have the other phenotype that come to the hospital, build up that cough and wheezing over days, and this kid staying in the hospital for 3 to 4 days and is still wheezing, and then they call us for this kid for a consult, which is supposed to be the reverse. Because that one, the first phenotype, have more bronchospasm than inflammation. Is that making sense? And then when you have more bronchospasm than inflammation, when you give him the beta agonist, which is the drug of choice, a bronchodilator for a early phase asthma or bronchospasm, you were able to turn him around. But if he goes up that quick, if he goes down that quickly, he could go up that quickly, but also he can go back down that quickly. Is that making sense? The one they should not consult us on, or maybe they should for business, especially my residents are watching. So is the inflammation, because this one have more inflammation than spasm. And that's why they took them some time to get rid of that inflammation. Is that making sense? That's why the moms comes, and that could be also in the question you may have. The mom comes say, you know, I've been diagnosed by my pediatrician to have asthma. They put my kid in albuterol, and initially he was responding to it. Now he's not responding to it as usual. You got that question, correct? Is it a wrong diagnosis or what? No. This kid, most probably with time, developed more inflammation than spasm, and he needs the inhaled corticosteroid. So you tell the mom, continue with the albuterol that take care of the spasm, but then you need to take care of the inflammation. Is that making sense? Now, the other point, and I will go to the slides. The other point I want to tell you that asthma is what type of diagnosis? Clinical diagnosis. What that means. If they ask you in the board, and there is a mom bring her kid or a dad bring his kid very mad, he said, I was given the wrong diagnosis about my kid, and his pulmonary function test is normal. Normal pulmonary function test, does it rule a asthma? Nope. It's supposed to diagnose, help you to treat, but they should be normal between attacks. Is that making sense? So remember, it's a clinical diagnosis. Normal a pulmonary function test does not rule it out. Normal chest X-ray does not rule it out. Because you got confused, oh, it's normal. No, they should be normal. If they are not normal, this asthma is bad between attacks. And the same thing for the X-ray. So asthma is a clinical diagnosis. So what makes the diagnosis of asthma then? If it's a clinical, what you're going to ask this patient about? So you will cough and or wheeze in that sequence. Because you could have only cough, what we call cough variant asthma. So you cough and or wheeze, or shortness of breath. They could come in a different arrangement, but that's okay. They don't read the textbook, as I said. And then they partially or completely respond more than 2 to 3 times a year, and they partially or completely respond to albuterol. And I said partially respond to albuterol or completely, depends how much spasm and inflammation. Is that making sense? Or to make it fancy for us as a pulmonologist or a doctor, we say they show variable expiratory obstruction, which means what? They respond to albuterol, or you do methacholine challenge test on them, or they show variability in their beak flow. But it's respond, and you exclude other diagnoses because they could be asthma, could be our airway hyperreactivity, could be part of other diseases like cystic fibrosis, hypersensitive pneumonitis. So it's a clinical diagnosis, so it'd be easy to make. Okay, so I'll go back. So it's not one disease. many diseases, but what they have in common, the chronic inflammation and the spasm. So it's a heterogeneous disease, many phenotypes. And I cannot even, there is a phenotype, by the way, just to expand your perspective about asthma. Since we start to do the infantile PFTs, we found a phenotype. You born with low FEV1, and you just keep dipping. So I'm not going to go through that. So chronic airway inflammation, airway spasm. And spasm, what differentiates asthma from bronchiolitis? Defined by history, as we talked, of such as wheezing, shortness of breath, chest tightness, and cough that varies with time and intensity together with airway limitation. It's a clinical diagnosis. So, and when I said cough and or wheeze, because when you get a spasm, remember the physiology we talked in the morning about the resistant and the airway. You go in a spasm, you trigger your stretch receptors. That's why you cough. You narrow more, you start to have cough and expiratory wheeze. You narrow more, you start to have cough, expiratory wheeze, and inspiratory wheeze. You narrow more, you're not moving air, silent chest. So that's when they're supposed to come this way, though they may not come all through. Childhood asthma prevalence increased from 2001 to 2009, followed by plateau, then decline in 2013. Puerto Rican children have the highest prevalence in the United States. It's just epidemiological data, you have to remember it. You may be asked about it. There is geographical, socioeconomic disparities exist. There is the hygiene theory. We're not going to go through it, this one. So there's a lot going on there for asthma. I do believe that asthmatology will be a branch from pulmonology. So history, symptoms. When you take history, you look at the symptoms. You have to identify triggers because asthma is also, you may identify a trigger. Doesn't mean the absence of a trigger, there is no trigger, but you can identify it. Even when we do allergy testing, IgE, it means that we did not identify a trigger. Also, what type of pattern is this asthma? It is the wheezing, the spasm, there are many types, many phenotypes. Evidence of variable airway limitation, which means what? Make it simple, that they respond to albuterol, or you do a methacholine, or you do a peak flow, and there is variability in asthma. And I explain why there is variability on the airflow limitation asthma later on. And then if there's comorbidities, that actually makes your asthma uncontrolled, and I will explain them later on. So this is what you look. Asthma, you need a trigger. Trigger different than a cause, so you need a trigger. So asthma, it's spasm and inflammation, and that show it to you. Now, I'm going to teach you quickly how to read, and if you have any question later on and how to read pulmonary function test, stop me. I'll be more than happy to go over it. So let's go. Force vital capacity, FVC, is how much, when you fill up your lungs, how much you can get out if you keep exhaling out, usually 6 seconds, in 6 seconds. FEV1, how much you can blast out in the first second. So when you blast out air, you fill up your lungs, you blast, what you blast out, what you empty first, the large airway. So FEV1 reflects the large airway. Is that making sense? Okay. Then you need the ratio between FEV1 and FVC, and I'll come to it. Then FEF, forced expiratory flow, 2575. This showed you mid-flow, so it reflects what? Small airway. So 2575, small airway, FEV1, large airway. And then you have the peak expiratory flow rate. Now, why this is important? When we come to cystic fibrosis, you could be asked, and we will explain it, but if you have a plugging like cystic fibrosis, you have a thick mucus. If you plug first, which airway you plug first? The small airway. So they may ask you what will be affected first, a 2575 or FEV1 is the small airway. What reflects a small airway 2575? Is that making sense? Okay. Now, I'm going to teach you how to read this is the easiest way to read it, but doesn't mean there is no minor criteria. And it's more difficult but for your clinical practice, for your board exam, that could get you through pulmonary function test if you presented with pulmonary function test. So usually I ask myself 2 questions. This is when there are many numbers, by the way. That's how we make money. I make pulmonary, as a pulmonologist, we got paid well. I don't know if well or not. But there are many numbers to confuse everybody. So I ask myself, is this obstructive defect or restrictive defect? You have to have a system. Otherwise, you get lost with this number. So for obstructive defect, you look at FEV1. So you look at FEV1. Now, in pulmonary function test, to make it easy, it's a predicted values. And it's normal from 80% to 120. So anything that comes between 80%, the predicted value, to 120 is normal. So just remember, 80 to 120, okay? So, and they may ask you in the board, what's the most important variable to determine your pulmonary in determining your pulmonary function test? Height. Gender is important, ethnic group is important, weight is important, whatever is important, but what determines our pulmonary function test, the most important variable is height. Height. So you look for height. So you ask yourself, go back, you ask yourself, is this obstructive defect or restrictive defect? If it's obstructive defect, you forget all the numbers and look at FEV1. If it's less than 80, which is, we said 80 is the lowest normal, you will say, and this is very important, even the language you use, you will say it suggests obstructive. To confirm it, you look at the ratio between FEV1 and FVC. If it's less than 80, you confirm obstructive. As easy as this. This is the simplest way to read them. I cannot make it more simple than that. There's more into it, but that should get you through. So FEV1, forget all the numbers. Say for obstructive, I go for FEV1. Less than 80, yes. Let me look at the ratio. The ratio is less than 80. This is obstructive. If you want to know if there is a bronchodilator response, you need two together, not one enough, two. You look also at FEV1. If it increases after you give these 4 puffs of albuterol more than 12% or 200 ml in the volume of FEV1, then it is positive bronchodilator response. For restrictive, then you finish with the obstructive. See, there are like 20 numbers. You finish with them. Then you go to the restrictive. You look at FVC. If it's less than 80, you say it suggests restrictive. You did not confirm it. And usually spirometry, if you did a spirometry does not measure for you lung volumes. So you need to confirm it TLC, total lung capacity. So you will ask for volumes to put them in the box, you remember? So you will say this is suggestive of, if it's less than 80 of restrictive, then you will ask for TLC and lung volumes. If the TLC less than 80, you confirm restrictive. This is how to read PFTs. And if any question, then, so now let's practice. So this is I got this, there are more numbers, but I can't fit the screen for them. So, and I look, so is this, the first question, is this obstructive? I look at the FEV1. The FEV1, the reference 1.67, it's 170. So if this over this is 102. So 102 is normal. So there's no suggestion of obstructive. To confirm it, I look at the ratio FE1 over FEC. It's 88. There is above 80. There is no obstructive defect. Then I ask myself, if this is restrictive, I look at FVC. 105 is normal. Then I will read these pulmonary function tests. No obstructive defect and no suggestion of restrictive defect. So this is normal spirometry. Now, in asthma, things, when they present you, and I can see from here some of the tables, when they present you with the tables, you get lost, and you don't want to read them or even look at them for the test, because you think that you have to memorize all this. I'm going to simplify it, but I need you to follow up with me, and hopefully I make it easy to remember it. So you need to know these things, that when somebody is not on medication, we need to assess severity. Because severity will tell you, which is impairment and risk, will tell you if you need to start, which medication you have to start. And then when we put them in medication, we need to assess control. And you look for impairment and risk. And I will go over through this. Now, as a pulmonologist, I need the kids to be what? My goal to be successful in treating asthma, I need them to be intermittent, well-controlled, which means I need them to be on beta agonists as needed, and they are well-controlled. If I manage all comorbidity, triggers, and everything, that's my aim. So severity, intermittent, mild persistent, moderate persistent, severe persistent, well-controlled, not well-controlled, very poorly controlled. Now, and I want you to follow here, because so for impairment, you don't need to, I'll give you a slide that summarizes all this. But what I need you to know in the impairment depends on the age. So there are 4 things. Like if you ask me when I treat asthma, what are the goals of treating asthma? I'll tell you 4 things. You as practicing physicians, you will have to look into these 4 things, which are, you need daytime symptoms less than 2 days a week. Daytime symptoms, which is there, you see, 2 days a week. You need no night symptoms. Asthma is worse at night. You know why? Nights are colder, but that's not the only reason. The trigger could be in the bed. That's not the only reason. The most important reason, and you may be asked for that, we make steroid internally, and the lowest level of steroids is at 12 to 1 in the morning. And that's why when I sit in the emergency room, I wait for the asthma and the allergy to come after midnight. That's true, because they're not protected by their own steroids. So I want less than 2 days a week of daytime symptoms. The second goal in treating asthma, no night symptoms, no limitation of activity, and no limitation of activity and normal pulmonary function test or nearly normal pulmonary function test when they are able to do it. So these are the 4 goals, and this is GINA, by the way, the Global Initiative for Asthma. These are the 4 goals, and whatever you do asthma test, they address these 4. And even the tables, if you look, symptoms, less than twice a week. Nighttime awakening, this means night symptoms. Beta agonists related to the symptoms, because if you have night symptoms and day symptoms, there. Activity limits. So this kid cannot do, because this age group is 0 to 4, they cannot do BFT, so his BFT dropped. When we go forward for 5 and above, then BFT become a factor. But remember these 4 things. Even clinically, when you come to a patient, when I interview a patient and said, how many times you use albuterol? Oh, once a month. Okay, there is no cure for asthma, correct? We don't cure, we cannot. I mean, I hope you guys will find a cure for asthma. For so far, we can control it, no cure. So if there is no cure for asthma, then I need it to be controlled. If I need it to be controlled, then I say, how many symptoms? Oh, once a month I use albuterol. Did you have any nice symptoms? Do you wake up coughing? No. Do you exercise? No limit. Do you cough without exercise? And I'm not gonna, sometimes we tell them for exercise-induced asthma to use a albuterol within half an hour before exercise, correct? And I'll come back to this. And then, no. So did you do any PFT? Yes, it's normal. Then I start to think that he is controlled. I need to step down in his management, okay? So I'm gonna differentiate between why we do albuterol every 4 hours, guys. Why we tell the patients, and I'm gonna highlight this, why we tell the patient if you need more than 4 hours to come to the hospital. Because the duration of the effect or the duration of effect of albuterol is 4 hours. So if you already give him a treatment and he doesn't need treatment after 2 hours, if you give him another albuterol, you do it, but you know that if the effect is still there, correct? And why you have to give them albuterol for exercise, because that's also about the question. They ask you what you have to do for exercise-induced. There are 2 terminology, and I will differentiate for you, bronchospasm and exercise-induced asthma. He will ask you, what's the treatment of choice for exercise-induced asthma or bronchospasm? The drug of choice, albuterol, beta agonist, short-acting beta agonist within half an hour. Why half an hour? Because the onset of action of albuterol takes half an hour. So up to half an hour. So you need to treat them, so when they exercise, they already have the albuterol working. Is that making sense? So the albuterol, it's not the inhaled corticosteroids, the drug of choice for exercise-induced asthma. Now, there are 2 terminology people get also a mix-up about them. The first terminology said exercise-induced bronchospasm and exercise-induced asthma. They are different, by the way. Exercise-induced asthma, you have asthma, and the exercise is a trigger factor. And up to 80% of asthmatic, they could be triggered by exercise. And the treatment of choice, yes, you'd give them albuterol, but the longer treatment of choice, you put them in a controller. Because if you control your asthma, they will stop being triggered by exercise. Is that making sense? Exercise-induced bronchospasm, these kids or these adults only get the spasm when they exercise, never get inflammation. They will have normal pulmonary function test. There is no inflammation. If you do a chest x-ray or you do any inflammatory marker on them, there is no inflammation. They only get the bronchospasm and their treatment albuterol, and they don't need inhaled corticosteroids. So there is difference between exercise-induced bronchospasm and exercise-induced asthma. Now, so we finish with the 4 things for the impairment, and we come impairment for control and severity. There are 3 risks that you try to prevent. So we talked about the 4 goals, which is the impairment goals. There are 3 risks, depends on the age also. Number of flare-ups. They don't like us to say exacerbation because flare-up means there is inflammation and you flare up because asthma is inflammation. The second thing, you don't want them to leave a abnormal obstructive defect in their pulmonary function test, correct? Because if you leave asthma is a chronic inflammation. If you leave a chronic inflammation in their airway, there's kids who will remodel whatever happened. This chronic inflammation, as I said earlier, could be replaced by fibrous tissue and hypertrophy so they could go to airway remodeling, and then they will change from reversible obstruction to fixed obstruction. So the risk is decreased number of exacerbation. The second risk you want to decrease, that should be no defect, obstructive defect. The third one, you don't want side effects of medication. So these are the risks that we try to prevent. Then you apply them with age. So if you go this age, 5 to 11, you see the pulmonary function test came with different, and then you have the number of exacerbation. If you go to above the age of 12, then you start to do impairment and what's their normal FEV1 over FVC. But truly, this is the basic of all these tables, which you would not be able to memorize, but remember what I told you. Because that will get you through the question, hopefully, through answering all these questions. Now, the control are the same. There's impairment and there's the risk, and these are the 3 risks. Reduction in lung growth, which means that you have inflammation, could become chronic, remodeling, changing in the lungs, exacerbation, and treatment-related adverse effects. And this is, you see it more with the control. Now, let's make it, and I will summarize that for you. Now, the concept also behind this also, and it's 0 to 4, 5 to 12, above 12. And you can, by the way, if you want to memorize it, you are more than welcome. I'm not against that. But I want you to know the concept so it becomes easy for you. So I said I need these kids to be beta agonists as needed, which means intermittent will control, correct? So if they are, step 1, if they are intermittent, well controlled, then it's as rescue treatment, as needed, short acting beta agonist. If the kid comes to me, we reassess them somewhere between 2, and remember this, between 2 to 6 weeks. That's what this table says for the board. But usually I assess them between 4 to 6 weeks. I need the inhaled corticosteroids. If you started today, need a week to kick in. So does not work as needed. I know there is literature coming now as needed, but that's not now, not mainstream. So if you use inhaled corticosteroids, you have to use at least 6 to 8 weeks to see an effect. It's the cumulative effect of the inhaled corticosteroids over time to decrease that inflammation. So that's one. So I will reassess them 4 to 6 weeks between each step. That's one. I need at least to be changed in severity over 3 months. Like if they became well controlled, I will leave them for 3 months without playing with anything, because then I can change their severity from moderate to mild, or from severe to moderate to mild. So remember these. So they come to me. This is how you do it, and even in the board or in your practice. I see them after 4 weeks. He's in albuterol as needed. I made the diagnosis he's in albuterol as needed because remember we said severity, when I assessed him initially for severity, he came to be mild intermittent, according to the 4 things. And then severity is important to start medication. I put him in albuterol as needed. He came 4 to 6 weeks. Do you have any nice daytime symptoms? More than twice a day. If they have more than twice a day, they become persistent. Twice a day and more, the rule of 2. We'll come to it. So you need inhaled corticosteroids, correct? Because if you go to mild persistent, more than 2 days a week, 2 days a week, correct? So they become, if more than 2 days a week, then mild persistent. Do you have nice symptoms? They're supposed to have no nice symptoms. If they said yes in the board that they have nice symptoms, you are persistent. Because in the intermittent, there is no nice symptoms, correct? If they answer anything for this, like 1 yes, 2 yes, 3 yes, 4 yes. If they are 2 yes, we call them partially controlled. 3 or 4 yes, and these 4 things I mentioned before, then it become what? Uncontrolled, poorly controlled, not well controlled. So if they answer 1, if they have, do you have limitation when you cough and wheeze? Yes, I cough and wheeze with activity. Then you need inhaled corticosteroids. Is that making sense? So it's easy. From this story, from the scenario, you could say where. Now, where at, we'll come to it. Now, so the next step to put him in inhaled corticosteroids, because that's the drug of choice for a late phase asthma. You start with the low dose to avoid, because the risk is side effects of medication, correct? Then you could go from low dose. Now, cromolyn, I don't think anybody use it for the board. It's up to you. And, montelukast, singular, you can use it. The drug of choice is inhaled corticosteroids. And there is a reason I will not put them in inhaled corticosteroids, but it's a choice there for the mild. Okay? Then, if they come back in 2 to 4 weeks, I reassess them according to the 4 things and the 3 risks, and they're still not controlled. Before I move on, I cannot just do medication because I'm wrong. I need to assess if there is something made them not responding, because they could be not responding or not taking it, or there's something. Like what? The most common, and this is in the board, you may see it, the most common cause of a not responding to medication in asthma is poor compliance, correct? And we don't like nowadays, Jenna does not like compliance, they like adherence, because compliance means that you instruct him, he did not follow it. Adherence means that you have a mutual contract with him. So use not adherent to it. So, or poor technique. He's not using the nebulizer, he's showering with a nebulizer. Instead of putting it in, he's using the air chamber and the spacer. He's not really using the right technique. It's whistling to him. He does not know when the air chamber whistles, what does it mean? It means that he went fast. Never seen. So there is things. There's also comorbidity makes your asthma uncontrolled. So before I jump to put him in a medium dose, I saw, this kid, adherent to medication, use the right technique, but he snores. He witnessed apneas, restless sleeper. Obstructive sleep apnea makes your asthma uncontrolled, because obstructive sleep apnea increases your body inflammation. When I tell you there is body inflammation, where is that inflammation in your body? Airway is one of them, correct? So if asthma is airway inflammation, anything increase your body inflammation will increase your airway inflammation and trigger you, correct? That makes sense. This kid has sinusitis. So I'll treat with antibiotics the sinusitis before I go to the next step. Before we thought that sinusitis is post-nasal drip that causing it, correct? It's not the post-nasal drip. Sinusitis also increase your body inflammation. Allergic rhinitis makes your asthma uncontrolled. If the kid is a teenager, allergic bronchopulmonary aspergillosis makes him. Environmental factors. That's why when we're not controlling, we said IgE. We send for the common respiratory panel to see if there is, because if you give him the medication twice a day, the inhaled corticosteroid usually twice a day, but he's exposed 8 hours for it, then we are not going to fix him, correct? So each step you have to assess. Then you go to low, medium dose, then you start. When you reach a medium dose and it's still not controlled, should I add LABA? Or should I add montelukast? LABA is okay, but you have to keep your mind. Usually, I'm not going to make it complicated. I usually try to find out if they have eosinophilic asthma or neutrophilic. Neutrophilic LABA works better. For eosinophilic, singular or montelukast works better, but you don't need that. But what I want you with LABA, there is a black label on it, because these kids could present with asthma not responding to albuterol, and they could die if you keep it. That's why I do believe this is because of tachyphylaxis. Because if you give them beta agonists, long-acting beta agonists every day, they downgrade the receptors. Then when they have a spasm, the receptors not that many to respond to albuterol, this could lead. So if you put them in LABA, you have to always to reassess when you can get them. And there is no LABA alone. So if you have in the board, they said in LABA without inhaled corticosteroids, that's the wrong answer. LABA should not be, long-acting beta agonists should not be given without inhaled corticosteroids, period. And then, now, in this, they will tell you also you can go to the high dose, and then even a short course of steroids or a daily steroids. And this is for you here. For your practice, for the board, for your practice, we found now studies are showing that when you reach a medium dose of inhaled corticosteroids, you plateau the effect. If you go to a high dose, you just increase the unwanted side effects. So usually for my practice, from the recent literature, that when I reach a medium dose of inhaled corticosteroid, I stop. And this is the same thing for every age. If you wanna, I just said, you are free to memorize it, but I hope I make it easy. Now, this is what you need to remember for the board. If you will get through things. But read, understand what I told you, but this could help you a lot. So the rule of twos. So if you don't want to look at the table, I advise you to look at the tables. I advise you to read the tables the way I told you and to look into it. I did not say not to look at it. But if you don't have a time, so if it's 2 days a week, but not daily, more than 2 by 2, rules of 2, more than 2 nights a month, it's mild persistent. If they ask you, your drug of choice, low dose inhaled corticosteroids. If it's daytime, look, the nights are less frequent. If it's daytime symptom, daily, and more than 1 night a week, then it's moderate persistent. You do low dose inhaled corticosteroid, LABA, medium dose of inhaled corticosteroids. That's your treatment of choice. If it's continual symptoms, day, night, exercise, everything he answered yes for the 4 I mentioned, then high dose, because that's what they want you to answer, LABA and oral steroids. This is summarize this, but you need to understand what you check, because if you don't know what your 4 goals of treating asthma, when you read this question, you may get lost. Is this control or not? Use these 4 things. Daytime symptom, the night symptoms, PFTs, and exercise limitation. If you use them, if 2 answer, 1 or 2 yes, partially uncontrolled, 3 to 4 yes, uncontrolled, and then you can decide. So we said obstructive reflux makes your asthma uncontrolled. And you could understand when you have asthma, you have airway inflammation, you narrow your airway, your resistance goes to the session before, goes to the power of 4. So you create a lot of negative pressure. Instead of -5, you may produce -25, -30, -50. That negative pressure helps us to vacuum air in to overcome the obstruction in our airway. But in the same time, what it does, it brings acid up, correct? It's excessive negative pressure. So, and when you reflux, I mean, if you remember Bernstein in the past got dogs, put some acid in the lower esophagus, they got through the vagus spasm. So reflux could cause a spasm. Reflux, if it's caused aspiration makes your asthma uncontrolled. Obstructive sleep apnea. There is many literature right now talking about, the relation between obesity and uncontrolled asthma. We did not need, good to have literature, but it makes sense. Because asthma is airway inflammation. You know what's the new definition of overweight, obesity? Chronic slow inflammation. We measured the inflammatory markers. We found that IL-6 is 6 times more than others. So if obesity is a state of inflammation, where is that inflammation going to be increased? Airway is part of it. So obesity causes asthma uncontrolled. Vitamin D deficiency makes your asthma uncontrolled. Because we thought vitamin D is good for the health of bone. We found that vitamin D it's really essential for T-cell immunity. And if you are vitamin D deficient, you may have uncontrolled asthma. So you have to look at the comorbidities that could be, because whatever medication you do, it may not help. And also when you have a kid who's allergic, who you did IgE, or when he goes out in the grass while his dad cutting the grass or his mom cutting the grass, you know that this kid, if he's not controlled, he could be a candidate for immunotherapy. So you will also ask for the allergist, and I'm sure they will talk about that. So we talked about what are the asthma goals. These are the 4 asthma goals. No cure in asthma, but there is control. Optimize outcome, future risk of exacerbation, or we like to call it flare-up, a fixed airway limitation. We don't want them to have airway remodeling. And if we can, sometimes you can prevent it, but the drug of choice to prevent remodeling is inhaled corticosteroids or slowing it down. And we need to minimize side effect of asthma medication. So we need a quick relief, rescue, albuterol. Now, this is a board question. If you're not going to ask for it, it's going to be weird. I'm not sure why. So they come, and this is the case. And I will explain all this slide in that question. 8 years old. Mom, dad coming so mad, shouting at you. Yeah, that's okay. And they said, I give her albuterol through nebulizer. She becomes shaky and her heart bounding. I don't like this. So your next step, discontinue albuterol. Give them leave albuterol. What's they call Zapanex. or give them ipratropium. So this is the answer. The answer, you give them a spacer or air chamber. And I will explain to you why. Let's go to the first one, levoalbuterol. They thought that albuterol has two domains. Beta agonist has two domains, right and left. They thought that the left is responsible for the effect, bronchodilator effect, and the right is causing the side effects. They said, okay, we'll make a new medicine only with the left domain. That's levo means left. So then they did it. They found the literature now, the evidence is so clear, there is no difference, period. So that's a wrong answer. It's very expensive, it's not called for, should be no existence, except if you want to charge the insurance more money. That's the only thing. Sometimes you feel that. No. So there is nothing. So ipratropium. Let me give them ipratropium or give them a Atrovent. The only indication for ipratropium bromide is two conditions one indication, but two things have to present. And this is evidence-based medicine. One should be moderate to severe flare-up of asthma. Two, and should be two with it in the emergency room, in the ED setting. There is no use in kids. Adults, they use, by the way. And you use it, adults, they use it. Kids, but that's not evidence-based. So it should be in the moderate to severe flare-up in the emergency room. Remember, the three treatments they give in the emergency room. That's the only indication. So why then if the kid has side effects, why I give him then air chamber and spacer? No, I don't want you to buy it like this. I want you to understand it. Because we found that what caused the side effects is the deposited albuterol or beta agonist in their mouth that they swallowed. So it's the swallowed one. So if we give him a spacer and air chamber, it will deposit in the air chamber, the spacer, and it will not deposit in their mouth. They will not swallow it. We will minimize the side effects. So your answer in the board is give them air chamber or a spacer. There's a difference between a spacer and air chamber, the valve, but that's a different talk. So as a controllers, they have inhaled corticosteroids, long-acting beta agonists always in combination with the inhaled corticosteroids. There is it's wrong answer. Whatever they make, it's a wrong answer, okay? It can be given. What I want you to remember here, there is leukotriene receptor antagonist, which is montelukast, zefilokast. It's what I said? Because mechanism of action, you'll be asked. It is leukotriene receptor antagonist. Because the mechanism of action of montelukast is anti-receptors. Remember this, please. Whereas xylotin is synthesis inhibitor. And remember that too. Don't forget it, please. Thiophanine, it is in that step up, step down. We don't like to use it in kids because it has very narrow therapeutic range from eye toxicity to CNS toxicity to GI. This is the major side effects. You have to remember them for thiophanine. Because of very narrow therapeutic range, they could cause CNS, eye, GI, the three of them. And omalizumab. Now, anti-IgE. So I'm going to ask you a question. Maybe our allergist today may touch on it, but I'll be asking, I think. So what happened with kids who have milk allergy or soya allergy? Milk protein allergy. How many kids you saw with milk protein allergy? A lot. Good number. Not a lot, correct? So what happened? Why they can't drink milk after the age of 5 or 6? Did you ask yourself that? Okay. So they can, by the way, if you get asked in the board, what happened to the soya, milk, egg white? These are three things. The kids outgrow the need of, outgrow that allergy. So the answer is reassure the mom, he will outgrow it between the age of 5 and 10. But did you ever ask yourself, allergy is determined by our genetics. Asthma is allergy, correct? I said no cure. So how come they got a cure? Did they get a cure? I'll make it more confusing. Not confusing, but more. So when you do IgE for them, IgE for milk, white, egg white, and for soya, they come positive, but they don't react. If you do skin test, it's negative. Why is that? We found that, and this is how we came with the anti-IgE, with the omalizumab. We found that your body, their body, with time produce IgG against IgE. So that's why they're always positive for IgE, but it's neutralized by the IgG. So we said, oh, that's how they outgrow it. It's a good idea. Let's use this to treat asthma. So we came with anti-IgE, and we call it a MAB, monoclonal antibody. You can choose the name, omalizumab. Is that making sense? So you have to have, in order to use it, you have to have, because asthma also, I told you, this is a heterogeneous group of diseases. You have to have what we call allergic asthma. So asthma now, more complicated a bit, allergic asthma, eosinophilic asthma, a neutrophilic asthma. So you need to have allergic asthma where you have certain range of IgE. Otherwise, if you don't have eosinophilic asthma, you may not have high IgE. What you are neutralizing, what you are attacking, correct? You need the IgE to be high to attack it. Two eggs, one stone, and two birds. No, daily long-term control, inhaled corticosteroid, most effective long-term control. So what's the drug of choice as a controller? Inhaled corticosteroids for persistent asthma. It seems like it's a line there, and it goes without saying. Remember it, because they may ask you, and then you get it confused. Persistent asthma, a controller. I'm not saying rescue. The drug of choice is inhaled corticosteroids. Then when you go low, medium dose, usually, as I told you, when you go to high dose, you start to see more of an unwanted effect. This depends on the dose and the delivery of method, because you try to... Now, before, when I did one of these boards I did in pediatrics, they asked me, what's the effect, the ultimate effect of inhaled corticosteroids in the height? You know what was the right answer? The right answer, kids eventually will reach their potential height, period. Means that no effect. Now the literature shows they will be an inch shorter maybe. So the answer changed. You see how medicine is? The good thing, you learn medicine, then it changes in you. I don't know what's correct. So now it does affect the ultimate height. As per the last board I did, it was not. As the board I'm gonna recertify again, it will. So the answer is, does affect the ultimate height. So when you give somebody, when you give inhaled corticosteroids, think about it. It reduces inflammation. The more inflammation you have in airway, the more exposed your nerve endings in the airway. The more exposed your nerve endings, the more twitchy your airway. So when you give inhaled corticosteroids, you get rid of the inflammation, your airway hyperreactivity decreased, and you get less spasms. Is that making sense? So it reduces airway inflammation, improve lung function, reduce the use of a quick relief medication, because the reason I just mentioned, the less inflammation, the less exposed nerve endings, the less irritable your airway, and fewer symptoms and exacerbation, which is the risk we try to avoid. And you need to remember that we give asthma action plan. It's a must that the kid leave with asthma action plan. What to do in an asthma action. To summarize it for you, to make it easy, they will do when they are green, yellow, red. In the green, they do their controller medication, whatever their controller medication you decide to give them. Then when they start to have symptoms, you have 3 scenarios in the asthma action plan. The first scenario, that you start to give albuterol every 4 hours. If they respond, they start to decrease it to every 6 hours to 8 hours. They stop coughing, you stop albuterol. That's the first scenario. The second scenario, you're doing albuterol every 4 hours, and it has been 24, 48 hours, and they not worsening but not improving. Then they have to call their doctor for maybe giving them a short course of steroids. The third scenario, they are really bad. You give them first treatment, and then you give them another one, and you call 911 or ship them to the emergency room. But asthma action plan, you need to be... Now, when they ask you about difficult asthma, we already touched on that. Difficult asthma means that the kid is in optimum therapy. You put him in what he should be on, but he is not controlled. And then, so when they ask you what's the most important, the next step, if they said what's the next step in difficult asthma, who's in maximum therapy, the next step is history and physical exam. So your answer for approaching difficult asthma, next step for somebody you label him as difficult asthma is history and physical exam. And what you look in the history, not just to go and because you want to take history, you have time. No, you will look for if he how frequent. You look at the control, the risk, and they look, is he taken? Is he adherent to it? Is a poor technique? Do you have any sinus pain, any facial pain? Do you have a drainage? How long you have the drainage? Because that's also a cause. Do you have any heartburn? You have any of this? If the kid, is he vomiting? You know, when you go out, you try to find the trigger, and you snore. You have witness apnea. Are you restless? So history and physical exam to go over these things that listed here. Oh, it's a wrong diagnosis. Because this kid has CF. I have a 13 years old, I have a kid who's 17 diagnosed at the age of 13 to have cystic fibrosis, and he was treated for asthma for his almost 12 years. So don't forget that you have to exclude things, because asthma or airway hyperreactivity could be part of other diseases. CF, they may have component of airway hyperreactivity. Hypersensitivity pneumonitis, they may have a component. By the way, IgG deficiency, they have a component of airway hyperreactivity. Believe it or not. So you have to make sure that it's not also vocal cord dysfunction. Vocal cord dysfunction, usually it's a female in teenager. She tell you the cardinal symptom that her throat close up on her. And then you say, this is a vocal cord dysfunction. Refer him to us. Don't worry about it. Now, asthma become a primary care physician care. You know, usually now they move asthma like ADHD under primary care. We got asked to see them if they diagnose any question. If you need from us a test, like do allergy skin testing, pulmonary function test, actually spirometry is available at the primary care now, at pediatrician offices. For specific therapy, like immune therapy. In children, 0 to 4, if you go, when you start to give them step 3, when you give them the low dose of inhaled corticosteroids, or step more than 4, when you start to give them inhaled corticosteroid with LABA. Or for additional education, you think that maybe we have an asthma educator in our practice and she will help him for education, and you don't have that in your office for education. Education is education. If they put you anything in asthma and has education, lean to education. Truly, it should be medication out there. Education is very important. We do have 2 asthma educators in our practice. An unsupervised 2-year-old was found having a choking episode. He's brought to the emergency department where he is noted to have decreased air entry and wheezing on the right side, which is the most appropriate next step. Very good. So you will say, should I do a Heimlich maneuver? He's coming to the emergency room, so it should be done later on, you know what I'm saying? This is where the confusing part maybe. So unsupervised, he's coming to the emergency room. He is already coming to the emergency room. So whatever intervention should be done there is done. It's rigid bronchoscopy. It's an ENT procedure because you need that telescope to remove the foreign body. It's not a flexible bronchoscopy for the pulmonologist, because with the flexible you will not be able to remove. So the diagnosis is a foreign body, correct? Now, usually 1 to 3, usually the age of 2, very typical. They start to do more mouthing and put things in their mouth. And then for a toddler, it's a food. Oh, he's running, he wants to play, and then do this. You know, the older children, they start to explore things with their mouth. They think that they got wiser. No, even inedible items. Trachea divide into right and left. That's what you need to understand for foreign body. The anatomy is important, and the gravity is important. So you trachea divide into right and left. Right is straight. When you go right, it is straight, almost straight shot. Left takes an angle. So if you aspirate anything liquid, when you got the laryngomalacia or a foreign body, it will go to the right because of the anatomy, because it's straight, and the gravity will bring it to the right middle lobe or the bases. If it's liquid, it will go to the bases. So that's where so usually it's in the right side, but it could go anywhere. Maybe he was playing, and while he's laying his left side, and then the gravity brought it to the left side. You know what I'm saying? But usually the right side. You need to get that history. 2 years old, what happened? He choke and cough and turn blue, then he's okay. So It could be asymptomatic for some time because if it's this large and went down to the airway, he's not anymore choking and coughing because it's past the trachea. It is already in the main right or intermedius. So you will not have any symptoms there, until he got infection or atelectasis or something. So it could be asymptomatic enteric. The absence of symptoms after the initial event does not rule it out. So it's very important to know the history and if there is a choking episodes. So if you have an obstruction, usually we said what initially? We said that intrathoracic, the diameter in the expiratory phase is smaller than the inspiratory phase. So if you have a foreign body in your airway, this will be, you will think it could be complete obstruction when he exhales or she exhales, correct? When the kiddo exhales. But in the inspiratory phase, since it is a bigger, it may have open a bit, so it will become a valve effect. So every time you do an expiratory breathing, you could completely obstruct. When you obstruct, you hyperventilate, inflate. And then if you hyperinflate too much on that side, you push the mediastinum away from the foreign body. This is the pathophysiology, correct? Then, if that foreign body is nasty foreign body and start to erode through the airway, it could erode to the blood vessel, so you could have hemoptysis, correct? And if it stays there, if you don't aerate or move air in that part of the lung, you're not moving secretion because the CD tried to push, but that foreign body push back. So you get some fluid retention, good media for infection, you could get infection later on. So they could cough because of the irritation in the airway. They could hemoptysis if it eroded through blood vessel. They could have pneumonia because of poor aeration and a airway clearance in that side. And they could collapse if it become complete. That's how you explain the symptoms. And this is what I explain. Most large in the right, 58. Primary symptom is transient or persistent cough. So cough, it's 75. Diagnosis is often not clear-cut and can be delayed without witness aspiration. Now what you do X-ray. If it shows asymmetrical hyperinflation, and most probably it happened if it's complete obstruction. Then which is up to 2/3, they said, okay, but it could be normal. But you may not be lucky and it have a valve effect where you do, if the kid can do expiratory film, as I explained it before, when in the expiratory film, you will trap air and hyperinflate and push the mediastinum to the other side. If the kid is not cooperating with you or the kid is hard to do the expiratory, so what will happen when we put the lung, if I put the right lung down, the weight of the other lung and the mediastinum will push in that lung, it will compress it, correct? So you are expecting, if you put him right decubitus, that the right lung will compress as you put him in the right side. If he have a foreign body, it will not compress. And then you know that there is a foreign body. Making sense? So it will not compress that, the lateral decubitus. And then fluoroscopy, nobody do it because you will go and do a scope and then you will see it and remove it in the same time if you have a high suspicion. But, it's an option. So you follow, if it's happening in front of you or you follow BLS recommendation for choking, recognize potential for difficult airway, especially if it's a large airway, a patient becomes unconscious, especially if it's in the trachea, a plan for advanced airway management. You have to know that foreign body could be ugly and the kid could get anoxic. If it's within foreign body, is rigid bronchoscopy to remove. We don't give antibiotics unless they already developed pneumonia and it's been late, like days before that. Okay, moving to cystic fibrosis. So most common lethal genetic disease in Caucasian. 1 every 3,000 Caucasian incidents, 1 every 3,000. And every 20 Caucasian, they will carry the gene. 1 every 20 carry the gene, the TR gene, defect gene. 1 every 4,000 to 10,000 Hispanic, African American, 1 every 15 to 20. So it's more common in a Caucasian American. It's autosomal recessive, remember that. It is recessive, so you need 2 genes to express the disease. Remember chromosome 7, please? Fibrosis, FV, 7. nearly 2,000 unknown CFTR mutation. What's the value of this? What's the value of this piece of information? 2,000 known CFTR mutation. You know what that means? That maybe there is another 2,000 unknown. So when I ask you in the question, they give you a case of cystic fibrosis and you tell you what's the confirmatory test, the definitive test for cystic fibrosis is, then they put you a sweat test, sweat chloride test, and they put you genetics. What's the answer? Because we don't know all the genetic mutations. Is that making sense? So then you got, but it's in the criteria. Yeah, it's in the criteria, but sweat test is the gold standard because there's few of them may not give you definite, but they are the exception, very rare. But all of them, what they have common, they have CFTR abnormality. So 50 of CF patients with Northern European background, they are homozygous for Delta 508. If you ask what's the most common, 508, Delta 508. Remember also, Delta 508. So you have five, remember number 7, number 5, 0, and 8. And you know how it goes with autosomal recessive. If they're both carrier, 1/4 affected, 1/4 not, and carrier to 50%. You don't need me to go through this because there's more things I want to talk about. If one parent has CF and so he has CF, and one is a carrier, what's the likelihood of having a child with a CF? Did I throw? Very good. So it's autosomal recessive. So you have two affected gene, then either it match with the defective gene or the normal gene. So if you calculate 50%, please do the math again because 50%. We do CF screening, prenatal, but now all states, before were 7 states, Colorado was the first, then we do newborn screening for everybody now. And we are blessed with that because that gives us an early diagnosis. I can explain cystic fibrosis in a simple way, but I just gonna need to go over these. So there is a combination of specific clinical characteristics. So there is a clinical picture of cystic fibrosis, which I'm gonna explain it to you. With biochemical, what biochemical? Sweat chloride test, correct? Or if we do a nasal potential difference. So the biochemical means the sweat chloride test. Or genetic markers. We're looking for the CFTR mutation. So this is the criteria to remember. You need positive newborn screen since we have it, or family history of cystic fibrosis, or the kid have meconium ileus, meconium plug. A kid who have below the age of 12 and have a nasal polyp. So nasal polyp before the age of 12, you have to rule out cystic fibrosis. There are 2 more causes for polyps. Uncontrolled allergic rhinitis was the third one. Aspirin, chronic use of aspirin. But if you have them, so plus one of the following, confirmed positive sweat chloride test. You did it more than 60, you're done. Or with and 2 CF, you have 2 identified mutation, or which is the rare that you have intermediate between 40 and 60, which is intermediate sweat chloride, but you have 1 gene or 0 gene, but the kid has a lot of symptoms of cystic fibrosis. There's now more names. I'm not gonna confuse it with CF-related metabolic syndrome, we call, but that's something also with the diagnosis. But remember, the gold standard is a CF, not the genetics. The sweat test, and you have to remember that more than 60 milliequivalent per liter sweat chloride is positive when with the other criteria there, like from what we mentioned. 40 to 60 is intermediate, and there is a criteria. You don't need to know it for a good sweat test. Should be in CF center, 30-minute correction. Should be not this a whole thing, the CF Foundation, but there is a good test and a bad test. And I will simplify it, but I just want to go over this. A false positive. So what will give you false positive? Malnourishment, and it seems in both, and I explain it in the false negative. Adrenal insufficiency because you have your electrolytes messed up, correct? autonomic dysfunction also that could affect the sweating, hypothyroid, and congenital adrenal hyperplasia. Usually I will say adrenal insufficiency and congenital adrenal hyperplasia has to do with our electrolytes, the regulation of our body electrolytes. That could make sense. Now, for the false negative, there are 3 reasons, but this is the list, so you can have it in the board. The 3 reasons: if you have edema, because you can't collect the sweat. So edema caused by malnourishment, that will cause hypoproteinemia, correct? So malnourished, hypoproteinemia, and peripheral edema. So these are 3 together. The second reason, lab error. And the third reason, actually, dehydration could be a reason. But the third reason also, if you are in that intermediate, where it's false negative, we know that some of them, they may have a intermediate sweat chloride test, but still have the cystic fibrosis. But remember these 3 causes for it. Lab error, hypoproteinemia due to malnourishment that led to edema, if you remember it this way. So what I want you to remember from this, and I will come, I promise you now, they could have chronic sinusitis. I said polyps below the age of 12, you do. Polyps, they are caused by 3 things: aspirin-induced, uncontrolled allergic rhinitis, and CF. But CF below the age of 12, you have to rule it out. The lungs of the cystic fibrosis, until they get colonized, and I will explain it, will be normal at birth. Then we will talk about it in the first year, they get infection, and this is how it comes to chronic bronchitis, obstructive lung disease, bronchiectasis. This is what I'm looking for. Okay, let me simplify cystic fibrosis from what we said. So what you need, cystic fibrosis, you have the CFTR, which is a transmembranous. It is a protein that transfer the chloride from inside the cell to outside. Is that making sense? This is the defect. You cannot bring chloride out of the cell. This is correct, except in one organ system, and that when you got confused in the board. What's the exception for that? Sweaty glands. Because you say, Dr. Mann, if the defect is in CFTR, they can't bring the chloride out of the cell. How come high sweat chloride is positive test, correct? Then all these thoughts happen in the board. So in the sweaty glands, CFTR protein is supposed to bring back the chloride inside the cell. Is that making sense? That's why we don't like them to go in hot weather. Because in hot weather, what happened to them, they sweat a lot and the CFTR is deficient. They can't bring water and electrolytes back. They got shocky and dehydrated. So the system that the reverse is the sweaty gland. So yes, high chloride is the positive test, not low chloride. So the CFTR, and I want you to focus here, the CFTR can't bring the chloride out. What follow a negative charge? A positive charge, which is sodium, correct? Then when you can't get the chloride out, you can't get sodium chloride, which is saline. If you can't get saline out, you cannot get water out. So you can't get the water out, so all secretion become dehydrated. Because most of our body secretions, 60–80% of them is water, correct? Is that so? You have thick mucus or thick secretions. That's the defect in the cystic fibrosis. So I can explain all of it by the following. So you need a tube in your body. So you identify a tube and plug it with that secretion. So let's go with the airway, with the lungs. If I ask you, cystic fibrosis is a lung parenchymal disease or airway disease? Airway disease. You need the tubes, correct? So cystic fibrosis is an airway disease. So when we look at any lung disease, we say it's parenchymal disease or airway disease. Cystic fibrosis is an airway disease. It will, because it's a thick mucus, it will plug the small airway first or the large airway first? The small airway. That's what the FEF 2575 got affected before FEV1. Now, in the lungs, there are any medication used in cystic fibrosis for the lungs, it will not go out of these 3 components. You plug, so you have abnormal mucus. When you have abnormal mucus, you cannot ventilate, that will cause inflammation there. And the more inflammation you have there, the more your mucus-producing cells and more your goblet cells try to produce more secretion to lubricate. The more lubrication, the more abnormal mucus. Then it's a good media, the secretion not moving anywhere because they are thick, obstructed, then you get infection. So the three components in cystic fibrosis, when you treat, I can challenge any of you, look at the medication that we give the cystic fibrosis, there will be these three. To address abnormal mucus, and I will tell you what are they, to address inflammation and infection. Now, let's see, abnormal mucus. What we do for abnormal mucus? Airway clearance, like VEST, correct? CBT, airway clearance, IBV, airway clearance. We try to move the secretion. What we did for abnormal mucus, we do hypertonic saline. Would hypertonic saline works? Yes. How's that? You said you cannot bring saline out from the cell. If you add it by nebulizing it, it will shift water. It makes sense, correct? Oh, what we do also, we do what we call pulmozyme. Pulmozyme is DNase. DNase, we have it in our body when we have an inflammation that who clears for us the pathways. So a DNase, it digests the DNA. What we found that there is too much neutrophils comes to the airway, and we know the reason. I know at least the reason that there is CFTR in the macrophages, and the macrophages they panic, they start to call more neutrophils, and they call them by interleukin 8. So interleukin 8 is the chemotaxis for more neutrophils that come to the airway. The neutrophils, they come in the airway and they die in the airway. When they die in the airway, they release their DNA. So you have abnormal mucus and you add to it DNA, you make it even more thick. So what we decided to do, nebulize a DNase, which is pulmozyme, and that will digest the DNA of the dead neutrophil and it will loosen the secretion. Make sense? So this is what we do. Now, all this new medication, Ocambi, and all this medication, what we call CFTR modifier, they also works in the abnormal mucus. So all this under the abnormal mucus. Make sense? A mucus system. You can mention it, but it's under abnormal mucus. Now, what we do for inflammation, you can do steroids, but side effects. Inhaled corticosteroid may help now. So what we did, we do azithromycin every other day. Do you know why we do azithromycin every other day as anti-inflammatory? They will tell me because of the Japanese, when they have what they call bronchiolitis, obliterating bronchiolitis, they found it's useful if you use azithromycin every other day. Yes, they are the one who discovered it. But there is explanation for it. Azithromycin is anti-IL-8. Remember what I said? Macrophages send the chemotaxis IL-8 to bring more neutrophils. So azithromycin is anti-IL-8. By the way, in asthma, there is more now literature that you can use azithromycin in neutrophilic asthma. So azithromycin is anti-IL-8. So this is what we use for inflammation. So abnormal mucus, inflammation, the second component. The third component is infection. It's easy. Get the mucus, see what you are colonized with, and treat it accordingly. That's it. Pseudomonas, most of the time, staph initially, then Pseudomonas. Pseudomonas usually need how many antibiotics to treat? 2. One of them should be aminoglycosides. Genta, Tobra, amikacin, whatever you want. Except where in the board they ask you if you get UTI and skin infection. You need 1 antibiotics for a Pseudomonas. So this is what it is. This is what cystic fibrosis. Now we done the lung, correct? So tubes, clogged. Pancreas. Which part of the pancreas will be affected? Exocrine. Why exocrine? Because they have the tubes. So you have thick pancreatic juice blocked because it's thick secretion. A block does not reach the intestine. Then you have maldigestion, correct? Then because you can't release these digestive enzymes in the intestine, you retain them in the pancreas, which later on, over years, could digest your beta cells, give you CF-related diabetes, because they auto-digest. If you're not releasing them, they're going to digest. If they cannot find food to digest, they will digest themselves. Suicidal. Bad. Maybe counseling. Okay? So if I ask you in the liver now, look, here, the list. Let's do the liver. What type of liver disease? Where are the tubes in the liver? Biliary, correct? So they got biliary disease. They got increased enzymes, then they got biliary cirrhosis. Could the sinuses be affected? Yes, because there's ducts for the sinuses and the abdomen. So you need a thick any secretion. What happened? Why they have absent vas difference? Male have absent vas deferens, most of them. Because the vas deferens, there is secretion with the semen. The semen is thick, comes in utero, and obstruct the vas deferens. Then when it obstructs the vas deferens, it push and compromise in the blood supply. So you got necrosis in utero. And that's why it got absent. What's the smallest point in our intestine? Small intestine, correct? Which part of the small intestine? Ileocecum, the terminal ileum. That's where, if they give you in the board, they said there is a calcified mass. There is meconium ileus and calcified mass. Where did this calcified mass have to be? In the terminal ileum, in the ileocecum, because the same thing, if it gets obstructed with meconium, it compress the airway, and if it I'm lung doctor, I have to say that. If it compress the small intestine, it could compress it and then push and compromise the vascular supply, and then you get necrosis. But there is no flora to cause bacterial pneumonitis, correct? It's a sterile one. And then you got calcification, because remember, if you have inflammation, you try to shut it down by fibrosis or calcification. That's why you may see a mass when they're born in the right side. That's why cystic fibrosis, they could come with constipation, and you know where the stool is retained? In the ileocecum. So enema may not help, because it's so far away. You have to go lightly or Marilax. And that's why when they have what we call DIOS, distal intestinal obstruction syndrome, they have it in the right side that mimic appendicitis. So it makes sense, correct? It's easy, just apply it. Which system you want. Female cervical secretion are thick, and that will cause infertility and become hard. Fallopian tubes, if there is secretion, they could get ectopic pregnancy. And when you obstruct an airway, to go back, with the time you obstruct it, you just obstruct the walls, and that will lead also to bronchiectasis. So apply it. You will find that what we said is that. So we talk about cystic fibrosis. They survive about the age of actually 40 something now, and this is 10 years. Most probably they survive because of CF center, all this. So male has a better survival than female, and because of the newborn screening test, the survival are improved. This is 37, it's old. We need more data. The last but not the least, primary ciliary dyskinesia. I'm going to give you the history because the history will help you to understand it, and then we're done. It was called before cartigenar syndrome or cartigenar syndrome, which is triad. It's there, cartigenar syndrome. It is the chronic sinusitis, dextrocardia, situs inversus, and bronchiectasis, correct? So, but then they called immotile cilia syndrome. So before, and I'll come back to cartigenar and I will explain to you the science. Because they thought that the cilia is not moving, they called it immotile. Then we found, no, it is moving, but it's not syncing together. And it is not, this could happen due to a virus, but it could be primary, you're born with it. So that's why the name. If you forget in the test, what's a primary ciliary dyskinesia, go through the name. You just remember the name. So it's a primary, means this is congenital, correct? When you take the ciliary biopsy, we take it usually from the nose, the inferior turbinates, you take it 2 to 3 weeks after a viral infection. Because it should be primary. The cilia could go, remember when I said influenza wipe out your cilia? If you have a viral infection, even a URI, if you take it from the nose, that could wipe out your cilia, and then you will be not able to tell if this is a primary or secondary. So remember the name, primary, so no secondary. What's secondary? URI or virus. So I should take the biopsy 2 to 3 weeks after when the kid is at baseline. Make sense? And it's cilia. And dyskinesia means there is motility, not immotile like before, but it's dyskinetic. Okay? Now, cartigenar, the patient presents with sinusitis because there is cilia supposed to move the secretion, like cystic fibrosis, thick mucus. Here, the cilia is not working. You got secretion retained in the sinus causes sinusitis. They have bronchiectasis because they don't have a good mucociliary mechanism, so secretion got also not moved out of that area. infection, overinfection, that will destruct the cartilage, the muscles, the area there, and when you destruct them, they dilate, they bronchiectasis. They become ectasis means dilatation. And why situs inversus and dextrocardia? Because, believe it or not, our organ system through in utero, the organs, they got made in the midline, and they reach their final destination by cilia. If you have ciliary dyskinesia, they may get it messed up. They could travel anywhere else, but inside the United States. I mean, inside the... Is that making... That's why situs inversus. So cilia is needed for final destination of the organs. So that's why. And this reduce male infertility. Are you surprised? There's a sperm moving with this cilia. So a treatment, if you need airway clearance, you need to help them to get the secretion, because that's the pathology. If I get rid of secretion, if I do a VAST, cough assist, IBV, CBT, I will move, and early antibiotics. Okay? Now, prognosis is good. What I want you to do, this is the arms, which is missing there, internal arms, external arms. What I want to do tell you about symptoms that associated with it. So you understand it. Where is the cilia in the brain? It moves the CF. So if you ask you, they will have hydrocephalus, the answer is yes, because the CF is not moving, it will accumulate, give you hydrocephalus, correct? Very good. They have infertility, yes. Now, if I tell you there is a cyst in the liver and cyst in the pancreas, how you explain it? So primary ciliary dyskinesia could lead to cyst in the liver and the pancreas. I'll tell you how's that. Because we have motile cilia, the one I talked about, but there is also a cilia that's a sensory cilia, which means what? You know, when cells divide, the cell line divide, they talk to each other like antennas. Oh, stop here, stop here, stop here. They call them sensory cilia. If you have abnormal cilia, part of the primary ciliary dyskinesia, actually the new name should be ciliopathy. They don't communicate, so over divide, they make the cyst. And that explains why they will have liver and pancreatic cyst. So if you see it in the board, yes, the answer, they could have it. So they could have hydrocephalus, infertility, bronchiectasis. They could have a ectopic pregnancy. Yes, correct? That would push the ovum down to the uterus. And with that, I am ending 5 minutes before.